Section 44 of Gray's Anatomy, Part 5. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recorded by Laurie Ann Walden. Anatomy of the Human Body, Part 5, by Henry Gray. The Hypophysis Cerebri. The hypophysis, pituitary body, is a small reddish-gray body, about 1 cm in diameter, attached to the end of the infundibulum of the brain and resting in the hypophyseal fossa. The hypophysis consists of an anterior and a posterior lobe, which differ from one another in their mode of development and in their structure. The anterior lobe is the larger, and is somewhat kidney-shaped, the concavity being directed backward and embracing the posterior lobe. It consists of a pars anterior and a pars intermedia, separated from each other by a narrow cleft, the remnant of the pouch or diverticulum. The pars anterior is extremely vascular, and consists of epithelial cells of varying size and shape, arranged in cord-like trabeculae or alveoli, and separated by large, thin-walled blood vessels. The pars intermedia is a thin lamina closely applied to the body and neck of the posterior lobe, and extending onto the neighboring parts of the brain. It contains few blood vessels, and consists of finely granular cells, between which are small masses of colloid material. The pars intermedia, in spite of the fact that it arises in common with the pars anterior from the ectoderm of the primitive buccal cavity, is often considered as a part of the posterior lobe which arises from the floor of the third ventricle of the brain. Although of nervous origin, the posterior lobe contains no nerve cells or fibers. It consists of neuroglia cells and fibers, and is invaded by columns which grow into it from the pars intermedia. Embedded in it are large quantities of a colloid substance histologically similar to that found in the thyroid gland. In certain of the lower vertebrates, for example fishes, nervous structures are present, and the lobe is of large size. From the pars intermedia a substance, no doubt an internal secretion, causes constriction of the blood vessels with rise of arterial blood pressure. This substance seems to have a stimulating effect on most of the smooth muscles, acting directly upon the muscle causing contraction. It also increases the secretion of the urine, of the mammary glands when in functional activity, and of the cerebrospinal fluid. Extracts of this lobe also influence the general metabolism of the carbohydrates by accelerating the process of glycogenolysis in the liver. The pars anterior exercises a stimulating effect on the growth of the skeleton, and probably on connective tissues in general. Enlargement of the hypophysis and of the cavity of the sella turcica are found in the rare disease acromegaly, which is characterized by a gradual enlargement of the face, hands, and feet, with headache and often a peculiar type of blindness. This blindness is due to the pressure of the enlarging hypophysis on the optic chiasma. Development of the hypophysis cerebri. This in the adult consists of a large anterior, consisting of the pars anterior and the pars intermedia, and a small posterior lobe. The former is derived from the ectoderm of the stomadeum, the latter from the floor of the forebrain. About the 4th week there appears a pouch-like diverticulum of the ectodermal lining of the roof of the stomadeum. This diverticulum, pouch of Rathke, is the rudiment of the anterior lobe of the hypophysis. It extends upward in front of the cephalic end of the notochord and the remnant of the buccopharyngeal membrane, and comes into contact with the under surface of the forebrain. It is then constricted off to form a closed vesicle, but remains for a time connected to the ectoderm of the stomadeum by a solid cord of cells. Masses of epithelial cells form on either side and in the front wall of the vesicle, and by the growth between these of a stroma from the mesoderm, the development of the anterior lobe is completed. The upwardly directed hypophyseal involution becomes applied to the anterolateral aspect of a downwardly directed diverticulum from the base of the forebrain. This diverticulum constitutes the future infundibulum in the floor of the third ventricle, while its inferior extremity becomes modified to form the posterior lobe of the hypophysis. In some of the lower animals the posterior lobe contains nerve cells and nerve fibers, but in man and the higher vertebrates these are replaced by connective tissue. A canal, craniopharyngeal canal, is sometimes found extending from the anterior part of the fossa hypophyseos of the sphenoid bone to the under surface of the skull, and marks the original position of Rathke's pouch, while at the junction of the septum of the nose with the palate, traces of the stomatial end are occasionally present. Fraser. The pineal body. The pineal body, epiphysis, is a small reddish-gray body about 8 mm in length, which lies in the depression between the superior colliculi. It is attached to the roof of the third ventricle near its junction with the midbrain. It develops as an outgrowth from the third ventricle of the brain. In early life it has a glandular structure which reaches its greatest development at about the 7th year. Later, especially after puberty, the glandular tissue gradually disappears and is replaced by connective tissue. Structure. The pineal body is destitute of nervous substance, and consists of follicles lined by epithelium and enveloped by connective tissue. These follicles contain a variable quantity of gritty material composed of phosphate and carbonate of calcium, phosphate of magnesium and ammonia, and a little animal matter. It contains a substance which, if injected intravenously, causes fall of blood pressure. It seems probable that the gland furnishes an internal secretion in children that inhibits the development of the reproductive glands, since the invasion of the gland in children by pathological growths which practically destroy the glandular tissue results in accelerated development of the sexual organs, increased growth of the skeleton, and precocious mentality. End of section 44. Section 45 of Gray's Anatomy, Part 5. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recorded by Laurie Ann Walden. Anatomy of the Human Body, Part 5, by Henry Gray. The Chromaphil and Cortical Systems. Chromaphil, or chromaffin cells, so called because they stain yellow or brownish with chromium salts, are associated with the ganglia of the sympathetic nervous system. Development. They arise in common with the sympathetic cells from the neural crest, and are therefore ectodermal in origin. The chromaphil and sympathetic cells are indistinguishable from one another at the time of their migration from the spinal ganglia to the regions occupied in the adult. Differentiation of chromaphil cells begins in embryos about 18 mm in length, but is not complete until about birth. The chromaphiloblasts increase in size more than the sympathoblasts, and stain less intensely with ordinary dyes. Later the chrome reaction develops. The aortic bodies differentiate first, and are prominent in 20 mm embryos. The paraganglia of the sympathetic plexuses differentiate next and last of all the paraganglia of the sympathetic trunk. The carotid body is completely differentiated in 30 mm embryos. After birth the chromaphil organs degenerate, but the paraganglia can be recognized with the microscope in sites ordinarily occupied by them. The paraganglia are small groups of chromaphil cells connected with the ganglia of the sympathetic trunk and the ganglia of the celiac, renal, suprarenal, aortic, and hypogastric plexuses. They are sometimes found in connection with the ganglia of other sympathetic plexuses. None have been found with the sympathetic ganglia associated with the branches of the trigeminal nerve. The aortic glands, or bodies, are the largest of these groups of chromaphil cells, and measure, in the newborn, about 1 cm in length. They lie one on either side of the aorta in the region of the inferior mesenteric artery. They decrease in size with age, and after puberty are only visible with the microscope. About 40 they disappear entirely. Other groups of chromaphil cells have been found associated with the sympathetic plexuses of the abdomen, independently of the ganglia. The medullary portions of the suprarenal glands and the glomus caroticum belong to the Chromaphil system. The suprarenal glands, glandulae suprarenalis, adrenal capsule. The suprarenal glands are two small flattened bodies of a yellowish color, situated at the back part of the abdomen, behind the peritoneum, and immediately above and in front of the upper end of each kidney, hence their name. The right one is somewhat triangular in shape, bearing a resemblance to a cocked hat. The left is more semilunar, usually larger, and placed at a higher level than the right. They vary in size in different individuals, being sometimes so small as to be scarcely detected. Their usual size is from 3 to 5 centimeters in length, rather less in width, and from 4 to 6 millimeters in thickness. Their average weight is from 1.5 to 2.5 grams each. Development. Each suprarenal gland consists of a cortical portion derived from the coelomic epithelium and a medullary portion originally composed of sympathochromaffin tissue. The cortical portion is first recognizable about the beginning of the 4th week as a series of buds from the coelomic cells at the root of the mesentery. Later it becomes completely separated from the coelomic epithelium and forms a suprarenal ridge projecting into the coelom between the mesonephros and the root of the mesentery. Into this cortical portion cells from the neighboring masses of sympathochromaffin tissue migrate along the line of its central vein to reach and form the medullary portion of the gland. Relations. The relations of the suprarenal glands differ on the two sides of the body. The right suprarenal is situated behind the inferior vena cava and right lobe of the liver and in front of the diaphragm and upper end of the right kidney. It is roughly triangular in shape. Its base, directed downward, is in contact with the medial and anterior aspects of the upper end of the right kidney. It presents two surfaces for examination, an anterior and a posterior. The anterior surface looks forward and lateralward, and has two areas, a medial, narrow, and non-peritoneal, which lies behind the inferior vena cava, and a lateral, somewhat triangular, in contact with the liver. The upper part of the latter surface is devoid of peritoneum, and is in relation with the bare area of the liver near its lower and medial angle, while its inferior portion is covered by peritoneum, reflected onto it from the inferior layer of the coronary ligament. Occasionally the duodenum overlaps the inferior portion. A little below the apex, and near the anterior border of the gland, is a short furrow termed the hilum, from which the suprarenal vein emerges to join the inferior vena cava. The posterior surface is divided into upper and lower parts by a curved ridge. The upper, slightly convex, rests upon the diaphragm. The lower, concave, is in contact with the upper end and the adjacent part of the anterior surface of the kidney. The left suprarenal, slightly larger than the right, is crescentic in shape, its concavity being adapted to the medial border of the upper part of the left kidney. It presents a medial border which is convex, and a lateral which is concave. Its upper end is narrow, and its lower rounded. Its anterior surface has two areas, an upper one, covered by the peritoneum of the omental bursa, which separates it from the cardiac end of the stomach, and sometimes from the superior extremity of the spleen, and a lower one, which is in contact with the pancreas and lienal artery, and is therefore not covered by the peritoneum. On the anterior surface, near its lower end, is a furrow or hilum, directed downward and forward, from which the suprarenal vein emerges. Its posterior surface presents a vertical ridge, which divides it into two areas. The lateral area rests on the kidney, the medial and smaller on the left crus of the diaphragm. The surface of the suprarenal gland is surrounded by areolar tissue containing much fat, and closely invested by a thin fibrous capsule, which is difficult to remove on account of the numerous fibrous processes and vessels entering the organ through the furrows on its anterior surface and base. Small accessory suprarenals, glandulae suprarenales accessoriae, are to be found in the connective tissue around the suprarenals. The smaller of these, on section, show a uniform surface, but in some of the larger a distinct medulla can be made out. Structure. On section, the suprarenal gland is seen to consist of two portions, an external or cortical, and an internal or medullary. The former constitutes the chief part of the organ, and is of a deep yellow color. The medullary substance is soft, pulpy, and of a dark red or brown color. The cortical portion, substantia corticalis, consists of a fine connective tissue network in which is embedded the glandular epithelium. The epithelial cells are polyhedral in shape and possess rounded nuclei. Many of the cells contain coarse granules, others lipoid globules. Owing to differences in the arrangement of the cells, three distinct zones can be made out. 1. The zona glomerulosa, situated beneath the capsule, consists of cells arranged in rounded groups, with here and there indications of an alveolar structure. The cells of this zone are very granular and stain deeply. 2. The zona fasciculata, continuous with the zona glomerulosa, is composed of columns of cells arranged in a radial manner. These cells contain finer granules and, in many instances, globules of lipoid material. 3. The zona reticularis, in contact with the medulla, consists of cylindrical masses of cells irregularly arranged. These cells often contain pigment granules which give this zone a darker appearance than the rest of the cortex. The medullary portion, substantia medullaris, is extremely vascular, and consists of large chromaphil cells arranged in a network. The irregular polyhedral cells have a finely granular cytoplasm that are probably concerned with the secretion of adrenaline. In the meshes of the cellular network are large anastomosing venous sinuses, sinusoids, which are in close relationship with the chromaphil or medullary cells. In many places the endothelial lining of the blood sinuses is in direct contact with the medullary cells. Some authors consider the endothelium absent in places, and here the medullary cells are directly bathed by the blood. This intimate relationship between the chromaphil cells and the bloodstream undoubtedly facilitates the discharge of the internal secretion into the blood. There is a loose meshwork of supporting connective tissue containing non-striped muscle fibers. This portion of the gland is richly supplied with non-medullated nerve fibers, and here and there sympathetic ganglia are found. Vessels and nerves. The arteries supplying the suprarenal glands are numerous and of comparatively large size. They are derived from the aorta, the inferior phrenic, and the renal. They subdivide into minute branches previous to entering the cortical part of the gland, where they break up into capillaries, which end in the venous plexus of the medullary portion. The suprarenal vein returns the blood from the medullary venous plexus and receives several branches from the cortical substance. It emerges from the hilum of the gland and on the right side opens into the inferior vena cava, on the left into the renal vein. The lymphatics end in the lumbar glands. The nerves are exceedingly numerous, and are derived from the celiac and renal plexuses, and according to Bergman from the phrenic and vagus nerves. They enter the lower and medial part of the capsule, traverse the cortex, and end around the cells of the medulla. They have numerous small ganglia developed upon them in the medullary portion of the gland. In connection with the development of the medulla from the sympathochromaffin tissue, it is to be noted that this portion of the gland secretes a substance, adrenaline, which has a powerful influence on those muscular tissues which are supplied by sympathetic fibers. Glomus caroticum, carotid glands, carotid bodies. The carotid bodies, 2 in number, are situated one on either side of the neck, behind the common carotid artery at its point of bifurcation into the external and internal carotid trunks. They are reddish-brown in color and oval in shape, the long diameter measuring about 5 millimeters. Each is invested by a fibrous capsule and consists largely of spherical or irregular masses of cells, the masses being more or less isolated from one another by septa which extend inward from the deep surface of the capsule. The cells are polyhedral in shape, and each contains a large nucleus embedded in finely granular protoplasm, which is stained yellow by chromic salts. Numerous nerve fibers, derived from the sympathetic plexus on the carotid artery, are distributed throughout the organ, and a network of large sinusoidal capillaries ramifies among the cells. Glomus coccygium, coccygeal gland or body, Luschka's gland. The glomus coccygium is placed in front of, or immediately below, the tip of the coccyx. It is about 2.5 mm in diameter, and is irregularly oval in shape. Several smaller nodules are found around or near the main mass. It consists of irregular masses of round or polyhedral cells, the cells of each mass being grouped around a dilated sinusoidal capillary vessel. Each cell contains a large
Section 46 of Anatomy of the Human Body, Part 5. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Anatomy of the Human Body, Part 5 by Henry Gray. The Spleen. Lion. The spleen is situated principally in the left hypochondriac region, but its superior extremity extends into the epigastric region. It lies between the fundus of the stomach and the diaphragm. It is the largest of the ductless glands, and is of an oblong, flattened form, soft, of very friable consistence, highly vascular, and of a dark purplish color. Development. The spleen appears about the 5th week as a localized thickening of the mesoderm in the dorsal mesogastrium above the tail of the pancreas. With the change in position of the stomach, the spleen is carried to the left, and comes to lie behind the stomach and in contact with the left kidney. The part of the dorsal mesogastrium which intervened between the spleen and the greater curvature of the stomach forms the gastrosplenic ligament. Relations. The diaphragmatic surface, facies diaphragmatica, external or phrenic surface, is convex, smooth, and is directed upward, backward, and to the left, except at its upper end, where it is directed slightly medialward. It is in relation with the under surface of the diaphragm, which separates it from the 9th, 10th, and 11th ribs on the left side, and the intervening lower border of the left lung and pleura. The visceral surface is divided by a ridge into an anterior or gastric and a posterior or renal portion. The gastric surface, facies gastrica, which is directed forward, upward, and medialward, is broad and concave, and is in contact with the posterior wall of the stomach, and below this with the tail of the pancreas. It presents near its medial border a long fissure, termed the hilum. This is pierced by several irregular apertures, for the entrance and exit of vessels and nerves. The renal surface, facies renalis, is directed medialward and downward. It is somewhat flattened, is considerably narrower than the gastric surface, and is in relation with the upper part of the anterior surface of the left kidney and occasionally with the left suprarenal gland. The superior extremity, extremitus superior, is directed toward the vertebral column, where it lies on a level with the 11th thoracic vertebra. The lower extremity or colic surface, extremitus inferior, is flat, triangular in shape, and rests upon the left flexure of the colon and the phrenico-colic ligament, and is generally in contact with the tail of the pancreas. The anterior border, margo anterior, is free, sharp, and thin, and is often notched, especially below. It separates the diaphragmatic from the gastric surface. The posterior border, margo posterior, more rounded and blunter than the anterior, separates the renal from the diaphragmatic surface. It corresponds to the lower border of the 11th rib and lies between the diaphragm and the left kidney. The intermediate margin is the ridge which separates the renal and gastric surfaces. The inferior border, internal border, separates the diaphragmatic from the colic surface. The spleen is almost entirely surrounded by peritoneum, which is firmly adherent to its capsule. It is held in position by two folds of this membrane. One, the phrenico-lional ligament, is derived from the peritoneum, where the wall of the general peritoneal cavity comes into contact with the omental bursa between the left kidney and the spleen. The lional vessels pass between its two layers. The other fold, the gastro-lional ligament, is also formed of two layers, derived from the general cavity and the omental respectively, where they meet between the spleen and the stomach. The short gastric and left gastroepiploic branches of the lional artery run between its two layers. The lower end of the spleen is supported by the phrenico-colic ligament. The size and weight of the spleen are liable to very extreme variations at different periods of life, in different individuals, and in the same individual under different conditions. In the adult, it is usually about 12 centimeters in length, 7 centimeters in breadth, and 3 or 4 centimeters in thickness, and weighs about 200 grams. At birth, its weight, in proportion to the entire body, is almost equal to what is observed in the adult, being as 1 to 350, while in the adult it varies from 1 to 320 and 400. In old age, the organ not only diminishes in weight, but decreases considerably in proportion to the entire body, being as 1 to 700. The size of the spleen is increased during and after digestion, and varies according to the state of nutrition of the body, being large in highly fed and small in starved animals. In malarial fever it becomes much enlarged, weighing occasionally as much as 9 kilos. Frequently in the neighborhood of the spleen, and especially in the gastro-lional ligament and greater omentum, small nodules of splenic tissue may be found, either isolated or connected to the spleen by thin bands of splenic tissue. They are known as accessory spleens, lion accessorius, supernumerary spleen. They vary in size from that of a pea to that of a plum. Structure. The spleen is invested by two coats, an external serous and an internal fibroelastic coat. The external or serous coat, tunica serosa, is derived from the peritoneum. It is thin, smooth, and in the human subject intimately adherent to the fibroelastic coat. It invests the entire organ, except at the hilum and along the lines of reflection of the phrenico-lional and gastro-lional ligaments. The fibroelastic coat, tunica albuginea, invests the organ, and at the hilum is reflected inward upon the vessels in the form of sheaths. From these sheaths, as well as from the inner surface of the fibroelastic coat, numerous small fibrous bands, trabeculæ, are given off in all directions. These, uniting, constitute the framework of the spleen. The spleen therefore consists of a number of small spaces or areolae formed by the trabeculæ. In these areolae is contained the splenic pulp. The fibroelastic coat, the sheaths of the vessels, and the trabeculæ are composed of white and yellow elastic fibrous tissues, the latter predominating. It is owing to the presence of the elastic tissue that the spleen possesses a considerable amount of elasticity, which allows of the very great variations in size that it presents under certain circumstances. In addition to these constituents of this tunic, there is found in man a small amount of non-striped muscular fiber, and in some mammalia, for example dog, pig, and cat, a large amount, so that the trabeculæ appear to consist chiefly of muscular tissue. The splenic pulp, pulpa lionis, is a soft mass of dark reddish-brown color, resembling grumous blood. It consists of a fine reticulum of fibers, continuous with those of the trabeculæ, to which are applied flat, branching cells. The meshes of the reticulum are filled with blood, in which, however, the white corpuscles are found to be in larger proportion than they are in ordinary blood. Large rounded cells, termed splenic cells, are also seen. These are capable of amoeboid movement, and often contain pigment and red blood corpuscles in their interior. The cells of the reticulum each possess a round or oval nucleus, and like the splenic cells, they may contain pigment granules in their cytoplasm. They do not stain deeply with carmine, and in this respect differ from the cells of the Malpighian bodies. In the young spleen, giant cells may also be found, each containing numerous nuclei or one compound nucleus. Nucleated red blood corpuscles have also been found in the spleen of young animals. Blood vessels of the spleen. The lyenal artery is remarkable for its large size in proportion to the size of the organ, and also for its tortuous course. It divides into 6 or more branches, which enter the hilum of the spleen and ramify throughout its substance, receiving sheaths from an involution of the external fibrous tissue. Similar sheaths also invest the nerves and veins. Each branch runs in the transverse axis of the organ, from within outward, diminishing in size during its transit, and giving off in its passage smaller branches, some of which pass to the anterior, others to the posterior part. These ultimately leave the trabecular sheaths and terminate in the proper substance of the spleen in small tufts or pencils of minute arterioles, which open into the interstices of the reticulum formed by the branch sustenticular cells. Each of the larger branches of the artery supplies chiefly that region of the organ in which the branch ramifies, having no anastomosis with the majority of the other branches. The arterioles, supported by the minute trabeculae, traverse the pulp in all directions in bundles, pencillae, of straight vessels. Their trabecular sheaths gradually undergo a transformation, become much thickened, and converted into adenoid tissue, the bundles of connective tissue becoming looser and their fibrils more delicate, and containing in their interstices an abundance of lymph corpuscles. W. Mueller. The altered coat of the arterioles, consisting of adenoid tissue, presents here and there thickenings of a spheroidal shape, the lymphatic nodules, Malpighian bodies of the spleen. These bodies vary in size from about 0.25 mm to 1 mm in diameter. They are merely local expansions or hypoplasia of the adenoid tissue, of which the external coat of the smaller arteries of the spleen is formed. They are most frequently found surrounding the arteriole, which thus seems to tunnel them, but occasionally they grow from one side of the vessel only, and present the appearance of a sessile bud growing from the arterial wall. In transverse sections, the artery, in the majority of cases, is found in an eccentric position. These bodies are visible to the naked eye on the surface of a fresh section of the organ, appearing as minute dots of a semi-opaque whitish color in the dark substance of the pulp. In minute structure they resemble the adenoid tissue of lymph glands, consisting of a delicate reticulum, in the meshes of which lie ordinary lymphoid cells. The reticulum is made up of extremely fine fibrils, and is comparatively open in the center of the corpuscle, becoming closer at its periphery. The cells which it encloses are possessed of amoeboid movement. When treated with carmine they become deeply stained, and can be easily distinguished from those of the pulp. The arterioles end by opening freely into the splenic pulp. Their walls become much attenuated, they lose their tubular character, and the endothelial cells become altered, presenting a branched appearance, and acquiring processes which are directly connected with the processes of the reticular cells of the pulp. In this manner the vessels end, and the blood flowing through them finds its way into the interstices of the reticulated tissue of the splenic pulp. Thus the blood passing through the spleen is brought into intimate relation with the elements of the pulp, and no doubt undergoes important changes. After these changes have taken place, the blood is collected from the interstices of the tissue by the rootlets of the veins, which begin much in the same way as the arteries end. The connective tissue corpuscles of the pulp arrange themselves in rows, in such a way as to form an elongated space or sinus. They become elongated and spindle-shaped, and overlap each other at their extremities, and thus form a sort of endothelial lining of the path or sinus, which is the radicle of a vein. On the outer surfaces of these cells are seen delicate transverse lines or markings, which are due to minute elastic fibrulae arranged in a circular manner around the sinus. Thus the channel obtains an external investment, and gradually becomes converted into a small vein, which after a short course acquires a coat of ordinary connective tissue, lined by a layer of flattened epithelial cells which are continuous with the supporting cells of the pulp. The smaller veins unite to form larger ones. These do not accompany the arteries, but soon enter the tubercular sheaths of the capsule, and by their junction form 6 or more branches, which emerge from the hilum and, uniting, constitute the lienal vein, the largest radicle of the portal vein. The veins are remarkable for their numerous anastomoses, while the arteries hardly anastomose at all. The lymphatics are described on page 711. The nerves are derived from the celiac plexus and are chiefly non-medullated.
Section 47 of Gray's Anatomy, Part 5. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by John K. Thomas, also known as Vern or John Coos. Anatomy of the Human Body, Part 5 by Henry Gray. 12. Surface anatomy and surface markings. 1. Surface anatomy of the head and neck. Bones, figure 1193. Various bony surfaces and prominences on the skull can be easily identified by palpation. The external occipital protuberance is situated behind, in the middle line, at the junction of the skin of the neck with that of the head. The superior nuchal line runs lateralward from it on either side, while extending downward from it the median nuchal crest, situated deeply at the bottom of the nuchal furrow. Above the superior nuchal lines, the vault of the cranium is thinly covered with soft structures, so that the form of this part of the head is almost that of the upper portion of the occipital, the parietal, and the frontal bones. The superior nuchal line can be followed lateralward to the mastoid portion of the temporal bone, from which the mastoid process projects downward and forward behind the ear. The anterior and posterior borders, the apex, and the external surface of this process are all available for superficial examination. The anterior border lies immediately behind the concha, and the apex is on a level with the lobule of the auricula, about 1 centimeter below and in front of the apex of the mastoid process. The transverse process of the atlas can be distinguished. In front of the ear, the zygomatic arch can be felt throughout its entire length. Its posterior end is narrow and is situated a little above the level of the tragus. Its anterior end is broad and is continued into the zygomatic bone. The lower border of the arch is more distinct than the upper, which is obscured by the attachment of the temporal fascia. In front and behind, the upper border of the arch can be followed into the superior temporal line. In front, this line begins at the zygomatic process of the frontal bone as a curved ridge, which runs at first forward and upward on the frontal bone, and then curving backward separates the forehead into the temporal fossa. It can be traced across the parietal bone, where, though less marked, it can generally be recognized. Finally, it curves downward and forward, and passing above the external acoustic meatus, ends in the posterior root of the zygomatic arch. Near the line of the greatest transverse diameter of the head are the parietal eminences on either side of the middle line. Further forward, on the forehead, are the frontal eminences, which vary in prominence in different individuals and are frequently unsymmetrical. Below the frontal eminences, the superciliary arches, which indicate the position of the frontal sinuses, can be recognized. As a rule, they are small in the female and absent in children. In some cases, the prominence of the superciliary arches is related to the size of the frontal sinuses, but frequently there is no such relationship. Situated between and connecting the superciliary ridges is a smooth, somewhat triangular area, the glabella, below which the nasion, the frontal nasal suture, can be felt as a slight depression at the root of the nose. Below the nasion, the nasal bones, scantily covered by soft tissues, can be traced to their junction with the nasal cartilages, and on either side of the nasal bone, the complete outline of the orbital margin can be made out. At the junction of the medial and intermediate thirds of the supraorbital margin, the supraorbital notch, when present, can be felt. Close to the medial end of the infraorbital margin is a little tubercle which serves as a guide to the position of the lacrimal sac. Below and lateral to the orbit, on either side, is the zygomatic bone forming the prominence of the cheek. Its posterior margin is easily palpable, and on it, just above the level of the lateral palpebral commissure, is the zygomatic tubercle. A slight depression about 1 centimeter above this tubercle indicates the position of the zygomatico-frontal suture. Directly below the orbit is a considerable part of the anterior surface of the maxilla, and the whole of its alveolar process can be palpated. The outline of the mandible can be recognized throughout practically its entire extent. In front of the tragus and below the zygomatic arch is the condyle, and from this posterior border of the ramus can be followed to the angle. From the angle to the symphysis, the lower rounded border of the mandible can be easily traced. The lower part of the anterior border of the ramus and the alveolar process can be made out without difficulty. In the receding angle below the chin is the hyoid bone, and the finger can be carried along the bone to the tip of the greater cornu, which is on level with the angle of the mandible. The greater cornu is most readily appreciated by making pressure on one side, when the cornu of the opposite side will be rendered prominent and can be felt distinctly beneath the skin. Joints and muscles. The temporomandibular articulation is quite superficial, and is situated below the posterior end of the zygomatic arch, in front of the external acoustic meatus. Its position can be ascertained by defining the condyle of the mandible. When the mouth opens, the condyle advances out of the mandibular fossa onto the articular tubercle, and a depression is felt in the situation of the joint. The outlines of the muscles of the head and face cannot be traced on the surface, except in the case of the masseter and temporalis. The muscles of the scalp are so thin that the outline of the bone is perceptible beneath them. Those of the face are small, covered by soft skin and often by a considerable layer of fat, and their outlines are therefore concealed. They serve, however, to round off and smooth prominent borders, and to fill up what would otherwise be unsightly angular depressions. Thus, the orbicularis oculi rounds off the prominent margin of the orbit, and the procerus fills in the sharp depression below the glabella. In like manner, the labial muscles converging to the lips and assisted by the superimposed fat fill up the sunken hollow of the lower part of the face. When in action, the facial muscles produce the various expressions, and in addition throw the skin into numerous folds and wrinkles. The masseter imparts fullness to hinder part of the cheek. If firmly contracted, as when the teeth are clenched, its quadrilateral outline is plainly visible. The anterior border forms a prominent vertical ridge, behind which is a considerable fullness, especially marked at the lower part of the muscle. The temporalis is fan-shaped and fills the temporal fossa, substituting for the concavity a somewhat convex swelling, the anterior part of which, on account of the absence of hair on the overlying skin, is more marked than the posterior, and stands out in strong relief when the muscle is in action. In the neck, the platysma, when contracted, throws the skin into oblique ridges parallel with the fasciiculi of the muscle. The sternocleidomastoidus has the most important influence on the surface form of the neck. When the muscle is at rest, its anterior border forms an oblique, rounded edge ending below on the sharp outline of the sternal head. The posterior border is only distinct for about 2 or 3 centimeters, above the middle of the clavicle. During contraction, the sternal head stands out as a sharply defined ridge, while the clavicular head is flatter and less prominent. Between the two heads is a slight depression. The fleshy middle portion of the muscle appears as an oblique elevation, with a thick, rounded anterior border best marked in its lower part. The sternal heads of the two muscles are separated by a V-shaped depression, in which are the sternohyoidus and sternothyroidus. Above the hyoid bone, near the middle line, the anterior belly of the didrasticus produces a slight convexity. The anterior border of the trapezius presents as a faint ridge running from the superior neutral line downward and forward to the junction of the intermediate and lateral thirds of the clavicle. Between the sternocleidomastoidus and the trapezius is the posterior triangle of the neck, the lower part of which appears as a shallow concavity, the supraclavicular fossa. In this fossa, the inferior belly of the omohyoideus, when in action, presents as a round cord-like elevation a little above and almost parallel to the clavicle. Figure 1195, front view of the neck. Arteries. The positions of several of the larger arteries can be ascertained from their pulsations. The subclavian artery can be felt by making pressure downward, backward, and medialward behind the clavicular head of the sternocleidomastoideus. Its transverse cervical branch may be detected parallel to and about a finger's breadth above the clavicle. The common and external carotid arteries can be recognized immediately beneath the anterior edge of the sternocleidomastoideus. The external maxillary artery can be traced over the border of the mandible just in front of the anterior border of the masseter, then about 1 centimeter, lateral to the angle of the mouth, and finally as it runs up the side of the nose. The pulsation of the occipital artery can be distinguished about 3 or 4 centimeters lateral to the external occipital protuberance, that of the posterior auricular, in the groove between the mastoid process and the auricula. The course of the superficial temporal artery can be readily followed across the posterior end of the zygomatic arch to a point about 3 to 5 centimeters above this, where it divides into its frontal and parietal branches. The pulsation of the frontal branch is frequently visible on the side of the forehead. The supraorbital artery can usually be detected immediately above the supraorbital notch or foramen. End of section 47. Recording by John K. Thomas, also known as Vern or John Coos. Web address www.val.
Section 48 of Gray's Anatomy, Part 5. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recorded by Laurie Ann Walden. Anatomy of the Human Body, Part 5, by Henry Gray. Surface markings of special regions of the head and neck, Part 1. The cranium, scalp. The soft parts covering the upper surface of the skull form the scalp and comprise the following layers. 1. Skin. 2. Subcutaneous tissue. 3. Occipitalis frontalis and Gallia aponeurotica. 4. Subaponeurotic tissue. 5. Pericranium. The subcutaneous tissue consists of a close meshwork of fibers, the meshes of which contain fatty tissue. The fibers bind the skin and Gallia aponeurotica firmly together, so that when the occipitalis or the frontalis is in action, the skin moves with the aponeurosis. The subaponeurotic tissue, which intervenes between the Gallia aponeurotica and the pericranium, is much looser in texture, and permits the movement of the aponeurosis over the underlying bones. Bony landmarks. In addition to the bony points already described, which can be determined by palpation, the following are utilized for surface markings. Auricular point, the center of the orifice of the external acoustic meatus. Preauricular point, a point on the posterior root of the zygomatic arch immediately in front of the external acoustic meatus. Asterion, the point of meeting of the lambdoidal, masto-occipital, and masto-parietal sutures. It lies 4 cm behind and 12 mm above the level of the auricular point. Pterion, the point where the great wing of the sphenoid joins the sphenoidal angle of the parietal. It is situated 35 mm behind and 12 mm above the level of the frontozygomatic suture. Inion, the external occipital protuberance. Lambda, the point of meeting of the lambdoidal and sagittal sutures. It is in the middle line, about 6.5 cm above the inion. Bregma, the meeting point of the coronal and sagittal sutures. It lies at the point of intersection of the middle line of the scalp, with a line drawn vertically upward through the preauricular point. A line passing through the inferior margin of the orbit and the auricular point is known as Reed's base line. The lambdoidal suture can be indicated on either side by the upper 2/3 of a line from the lambda to the tip of the mastoid process. The sagittal suture is in the line joining the lambda to the bregma. The position of the coronal suture on either side is sufficiently represented by a line joining the bregma to the center of the zygomatic arch. The floor of the middle fossa of the skull is at the level of the posterior 3/4 of the upper border of the zygomatic arch. The articular eminence of the temporal bone is opposite the foramen spinosum and the semilunar ganglion. Brain. The general outline of the cerebral hemisphere on either side may be mapped out on the surface in the following manner. Starting from the nasion, a line drawn along the middle of the scalp to the inion represents the superior border. The line of the lower margin behind is that of the transverse sinus, or more roughly a line convex upward from the inion to the posterior root of the zygomatic process of the temporal bone, thence along the posterior 2/3 of the upper border of the zygomatic arch, where the line turns up to the pterion. The front part of the lower margin extends from the pterion to the glabella about 1 cm above the supraorbital margin. The cerebellum is so deeply situated that there is no reliable surface marking for it. A point 4 cm behind and 1.5 cm below the level of the auricular point is situated directly over it. The relations of the principal fissures and gyri of the cerebral hemispheres to the surface of the scalp are of considerable practical importance, and several methods of indicating them have been devised. Necessarily, these methods can only be regarded as approximately correct, yet they are all sufficiently accurate for surgical purposes. The longitudinal fissure corresponds to the medial line of the scalp between the nasion and inion. In order to mark out the lateral cerebral sylvian fissure, a point, termed the sylvian point, which practically corresponds to the pterion, is defined 35 mm behind and 12 mm above the level of the frontozygomatic suture. This point marks the spot where the lateral fissure divides. Another method of defining the sylvian point is to divide the distance between the nasion and inion into 4 equal parts. From the junction of the third and fourth parts, reckoning from the front, draw a line to the frontozygomatic suture. From the junction of the first and second parts, a line to the auricular point. These two lines intersect at the sylvian point, and the portion of the first line behind this point overlies the posterior ramus of the lateral cerebral fissure. The position of the posterior ramus can otherwise be obtained by joining the sylvian point to a point 2 cm below the summit of the parietal eminence. The anterior ascending ramus can be marked out by drawing a line upward at right angles to the line of the posterior ramus for 2 cm, and the anterior horizontal ramus by a line of the same length drawn horizontally forward, both from the sylvian point. To define the central sulcus, fissure of Rolando, 2 points are taken. One is situated 1.25 cm behind the center of the line joining the nasion and inion. The second is at the intersection of the line of the posterior ramus of the lateral cerebral fissure with a line through the preauricular point, at right angles to Reed's baseline. The upper 9 cm of the line joining these 2 points overlies the central sulcus and forms an angle, opening forward, of about 70 degrees with the middle line of the scalp. An alternative method is to draw 2 perpendicular lines from Reed's baseline to the top of the head, one from the preauricular point, and the other from the posterior border of the mastoid process at its root. A line from the upper end of the posterior line to the point where the anterior intersects the line of the posterior ramus of the lateral fissure indicates the position of the central sulcus. The precentral and postcentral sulci are practically parallel to the central sulcus. They are situated, respectively, about 15 mm in front of and behind it. The superior frontal sulcus can be mapped out by a line drawn from the junction of the upper and middle thirds of the precentral sulcus, in a direction parallel with the longitudinal sulcus, to a point midway between the middle line of the forehead and the temporal line, 4 cm above the supraorbital notch. The inferior frontal sulcus begins at the junction of the middle and lower thirds of the precentral sulcus, and follows the course of the superior temporal line. The horizontal limb of the intraparietal sulcus begins from the junction of the lower with the middle third of the postcentral sulcus, and curves backward parallel to the longitudinal fissure, midway between it and the parietal eminence. It then curves downward to end midway between the lambda and the parietal eminence. The external part of the parieto-occipital fissure runs lateralward at right angles to the longitudinal fissure for about 2.5 cm from a point 5 mm in front of the lambda. If the line of the posterior ramus of the lateral cerebral fissure be continued back to the longitudinal fissure, the last 2.5 cm of it will indicate the position of the parieto-occipital fissure. The lateral ventricle may be circumscribed by a quadrilateral figure. The upper limit is a horizontal line 5 cm above the zygomatic arch. This defines the roof of the ventricle. The lower limit is a horizontal line 1 cm above the zygomatic arch. It indicates the level of the end of the inferior horn. Two vertical lines, one through the junction of the anterior and middle thirds of the zygomatic arch, and the other 5 cm behind the tip of the mastoid process, indicate the extent of the anterior horn in front and the posterior horn behind. Vessels. The line of the anterior division of the middle meningeal artery is equidistant from the frontozygomatic suture and the zygomatic arch. It is obtained by joining up the following points: 1. 2.5 cm, 2. 4 cm, and 3. 5 cm from these two landmarks. The posterior division can be reached 2.5 cm above the auricular point. The position of the transverse sinus is obtained by taking two lines, the first from the inion to a point 2.5 cm behind the auricular point, the second from the anterior end of the first to the tip of the mastoid process. The second line corresponds roughly to the line of reflection of the skin of the auricula behind, and its upper two-thirds represents the sigmoid part of the sinus. The first part of the sinus has a slight upward convexity, and its highest point is about 4 cm behind and 1 cm above the level of the auricular point. The width of the sinus is about 1 cm. The face. Air sinuses. The frontal and maxillary sinuses vary so greatly in form and size that their surface markings must be regarded as only roughly approximate. To mark out the position of the frontal sinus, 3 points are taken: 1. The nasion; 2. A point in the middle line 3 cm above the nasion; 3. A point at the junction of the lateral and intermediate thirds of the supraorbital margin. By joining these a triangular field is described which overlies the greater part of the sinus. The outline of the maxillary sinus is irregularly quadrilateral and is obtained by joining up the following points: 1. The lacrimal tubercle; 2. A point on the zygomatic bone at the level of the inferior and lateral margins of the orbit; 3 and 4. Points on the alveolar process above the last molar and the second premolar teeth, respectively. External maxillary artery. The course of this artery on the face may be indicated by a line starting from the lower border of the mandible at the anterior margin of the masseter, and running at first forward and upward to a point 1 cm lateral to the angle of the mouth, thence to the ala of the nose, and upward to the medial commissure of the eye. Trigeminal nerve. Terminal branches of this nerve, namely, the supraorbital branch of the ophthalmic, the infraorbital of the maxillary, and the mental of the mandibular, emerge from corresponding foramina on the face. The supraorbital foramen is situated at the junction of the medial and intermediate thirds of the supraorbital margin. A line drawn from this foramen to the lower border of the mandible, through the interval between the two lower premolar teeth, passes over the infraorbital and mental foramina. The former lies about 1 cm below the margin of the orbit, while the latter varies in position according to the age of the individual. In the adult it is midway between the upper and lower borders of the mandible; in the child it is nearer the lower border, while in the edentulous jaw of old age it is close to the upper margin. The position of the sphenopalatine ganglion is indicated from the side by a point on the upper border of the zygomatic arch, 6 mm from the margin of the zygomatic bone. Parotid gland. The upper border of the parotid gland corresponds to the posterior two-thirds of the lower border of the zygomatic arch, the posterior border to the front of the external acoustic meatus, the mastoid process, and the anterior border of sternocleidomastoideus. The inferior border is indicated by a line from the tip of the mastoid process to the junction of the body and greater cornu of the hyoid bone. In front, the anterior border extends for a variable distance on the superficial surface of the masseter. The surface marking for the parotid duct is a line drawn across the face about a finger's breadth below the zygomatic arch, that is, from the lower margin of the concha to midway between the red margin of the lip and the ala of the nose. The duct ends opposite the second upper molar tooth and measures about 5 cm in length. The nose. The outlines of the nasal bones and the cartilages forming the external nose can be easily felt. The mobile portion of the nasal septum, formed by the medial crura of the greater alar cartilages and the skin, is easily distinguished between the nares. When the head is tilted back and a speculum introduced through the nares, the floor of the nasal cavity, the lower part of the nasal septum, and the anterior ends of the middle and inferior nasal conchae can be examined. The opening of the nasolacrimal duct, which lies under cover of the front of the inferior nasal concha, is situated about 2.5 cm. Section 49 of Gray's Anatomy, Part 5. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recorded by Lauriann Walden. Anatomy of the Human Body, Part 5, by Henry Gray. Surface Markings and Special Regions of the Head and Neck, Part 2. The Mouth. The orifice of the mouth is bounded by the lips, which are covered externally by the whitish skin and internally by the red mucous membrane. The size of the orifice varies considerably in different individuals, but seems to bear a close relationship to the size and prominence of the teeth. Its angles usually correspond to the lateral borders of the canine teeth. Running down the center of the outer surface of the upper lip is a shallow groove, the philtrum. If the lips be everted, there can be seen, in the middle line of each, a small fold of mucous membrane, the frenulum, passing from the lip to the gum. By pulling the angle of the mouth outward, the mucous membrane of the cheek can be inspected, and on this, opposite the second molar tooth of the maxilla, is the little papilla which marks the orifice of the parotid duct. In the floor of the mouth is the tongue. Its upper surface is convex and is marked along the middle line by a shallow sulcus. The anterior 2/3 are rough and studded with papillae. The posterior third is smooth and tuberculated. The division between the anterior 2/3 and the posterior third is marked by a V-shaped furrow, the sulcus terminalis, which is situated immediately behind the line of the valate papillae. On the undersurface of the tongue, the mucous membrane is smooth and devoid of papillae. In the middle line, the mucous membrane extends to the floor of the mouth as a distinct fold, the frenulum, the free edge of which runs forward to the symphysis menti. Sometimes the ranine vein can be seen immediately beneath the mucous membrane, a little lateral to the frenulum. Close to the attachment of the frenulum to the floor of the mouth, the slit-like orifice of the submaxillary duct is visible on either side. Running backward and lateralward from the orifice of the submaxillary duct is the plica sublingualis, produced by the projection of the sublingual gland which lies immediately beneath the mucous membrane. The plica serves also to indicate the line of the submaxillary duct and of the lingual nerve. At the back of the mouth is the isthmus falcium, bounded above by the palatine velum, from the free margin of which the uvula projects downward in the middle line. On either side of the isthmus are the two palatine arches, the anterior formed by the glossopalatinus and the posterior by the pharyngopalatinus. Between the two arches of either side is the palatine tonsil, above which is the small supratonsillar recess. The position of the tonsil corresponds to the angle of the mandible. When the mouth is opened widely, a tense band, the pterygomandibular raphe, can be seen and felt lateral to the glossopalatine arch. Its lower end is attached to the mandible behind the last molar tooth, and immediately below and in front of this the lingual nerve can be felt. The upper end of the ligament can be traced to the pterygoid hamulus. About 1 cm in front of the hamulus and 1 cm medial to the last molar tooth of the maxilla is the greater palatine foramen through which the descending palatine vessels and the anterior palatine nerve emerge. Behind the last molar tooth of the maxilla, the carotid process of the mandible is palpable. By tilting the head well back, a portion of the posterior pharyngeal wall, corresponding to the site of the second and third cervical vertebrae, can be seen through the isthmus falcium. On introducing the finger, the anterior surfaces of the upper cervical vertebrae can be felt through the thin muscular wall of the pharynx. If the finger be hooked round the palatine velum, the choana can be distinguished in front, and the pharyngeal ostium of the auditory tube on either side. The level of the choana is that of the atlas, while the palatine velum is opposite the body of the axis. With a laryngoscope, many other structures can be seen. In the nasal part of the pharynx, the choana, the nasal septum, the nasal conchae, and the pharyngeal ostia of the auditory tubes can all be examined. Further down, the base of the tongue, the anterior surface of the epiglottis, with the glossoepiglottic and pharyngo-epiglottic folds bounding the valleculae and the piriform sinuses, are readily distinguished. Beyond these is the entrance to the larynx, bounded on either side by the aryepiglottic folds, in each of which are two rounded eminences corresponding to the corniculate and cuneiform cartilages. Within the larynx on either side are the ventricular and vocal folds, false and true vocal cords, with the ventricle between them. Still deeper are seen the cricoid cartilage and the anterior parts of some of the cartilaginous rings of the trachea, and sometimes, during deep inspiration, the bifurcation of the trachea. The eye. The palpebral fissure is elliptical in shape, and varies in form in different individuals and in different races of mankind. Normally it is oblique in a direction upward and lateralward, so that the lateral commissure is on a slightly higher level than the medial. When the eyes are directed forward, as in ordinary vision, the upper part of the cornea is covered by the upper eyelid, and its lower margin corresponds to the level of the free margin of the lower eyelid, so that usually the lower 3/4 are exposed. At the medial commissure are the caruncula lachrymalis and the plica semilunaris. When the lids are everted, the tarsal glands appear as a series of nearly straight parallel rows of light yellow granules. On the margins of the lids, about 5 mm from the medial commissure, are two small openings, the lacrimal puncta. In the natural condition they are in contact with the conjunctiva of the bulb of the eye, so that it is necessary to avert the eyelids to expose them. The position of the lacrimal sac is indicated by a little tubercle which can be plainly felt on the lower margin of the orbit. The sac lies immediately above and medial to the tubercle. If the eyelids be drawn lateralward so as to tighten the skin at the medial commissure, a prominent core can be felt beneath the tightened skin. This is the medial palpebral ligament, which lies over the junction of the upper with the lower 2/3 of the sac, thus forming a useful guide to its situation. The direction of the nasolacrimal duct is indicated by a line from the lacrimal sac to the first molar tooth of the maxilla. The length of the duct is about 12 or 13 mm. On looking into the eye, the iris with its opening, the pupil, and the front of the lens can be examined. But for investigation of the retina an ophthalmoscope is necessary. With this the lens, the vessels of the retina, the optic disc, and the macula lutea can all be inspected. On the lateral surface of the nasal part of the frontal bone, the pulley of the obliquus superior can be easily reached by pushing the finger backward along the roof of the orbit. The tendon of the muscle can be traced for a short distance backward and lateralward from the pulley. The ear. The various prominences and fossae of the auricula are visible. The opening of the external acoustic meatus is exposed by drawing the tragus forward. At the orifice are a few short, crisp hairs which serve to prevent the entrance of dust or of small insects. Beyond this, the secretion of the ceruminous glands serves to catch any small particles which may find their way into the meatus. The interior of the meatus can be examined through a speculum. At the line of junction of its bony and cartilaginous portions an obtuse angle is formed, which projects into the antero-inferior wall and produces a narrowing of the lumen in this situation. The cartilaginous part, however, is connected to the bony part by fibrous tissue, which renders the outer part of the meatus very movable, and therefore by drawing the auricula upward, backward, and slightly outward, the canal is rendered almost straight. In children the meatus is very short, and this should be remembered in introducing the speculum. Through the speculum the greater part of the tympanic membrane is visible. It is a pearly gray membrane, slightly glistening in the adult, placed obliquely so as to form with the floor of the meatus an angle of about 55 degrees. At birth it is more horizontal, and situated in almost the same plane as the base of the skull. The membrane is concave outward, and the point of deepest concavity, the umbo, is slightly below the center. Running upward and slightly forward from the umbo is a reddish-yellow streak produced by the manubrium of the malleus. This streak ends above, just below the roof of the meatus, at a small white rounded prominence which is caused by the lateral process of the malleus projecting against the membrane. The anterior and posterior malleolar folds extend from the prominence to the circumference of the membrane and enclose the pars flaccida. Behind the streak caused by the manubrium of the malleus, a second streak, shorter and very faint, can be distinguished. This is the long crus of the incus. A narrow triangular patch extending downward and forward from the umbo reflects the light more brightly than any other part, and is usually described as the cone of light. Tympanic antrum. The site of the tympanic antrum is indicated by the suprameatal triangle. This triangle is bounded above by the posterior root of the zygomatic arch, behind by a vertical line from the posterior border of the external acoustic meatus, in front and below by the upper margin of the meatus. The neck, larynx and trachea. In the receding angle below the chin, the hyoid bone, situated opposite the fourth cervical vertebra, can easily be made out. A finger's breadth below it is the laryngeal prominence of the thyroid cartilage. The space intervening between the hyoid bone and the thyroid cartilage is occupied by the hyothyroid membrane. The outlines of the thyroid cartilage are readily palpated. Below its lower border is a depression corresponding to the middle cricothyroid ligament. The level of the vocal folds corresponds to the middle of the anterior margin of the thyroid cartilage. The anterior part of the cricoid cartilage forms an important landmark on the front of the neck. It lies opposite the sixth cervical vertebra, and indicates the junctions of pharynx with esophagus, and larynx with trachea. Below the cricoid cartilage the trachea can be felt, though it is only in thin subjects that the separate rings can be distinguished. As a rule there are 7 or 8 rings above the jugular notch of the sternum, and of these the second, third, and fourth are covered by the isthmus of the thyroid gland. Muscles. The posterior belly of Digastricus is marked out by a line from the tip of the mastoid process to the junction of the greater cornu and body of the hyoid bone. A line from this latter point to a point just lateral to the symphysis menti indicates the position of the anterior belly. The line of omohyoideus begins at the lower border of the hyoid bone, curves downward and lateralward to cross sternocleidomastoideus at the junction of its middle and lower thirds, that is, opposite the cricoid cartilage, and then runs more horizontally to the acromial end of the clavicle. Arteries. The position of the common carotid artery in the neck is indicated by a line drawn from the upper part of the sternal end of the clavicle to a point midway between the tip of the mastoid process and the angle of the mandible. From the clavicle to the upper border of the thyroid cartilage, this line overlies the common carotid artery. Beyond this it is over the external carotid. The external carotid artery may otherwise be marked out by the upper part of a line from the side of the cricoid cartilage to the front of the external acoustic meatus, arching the line slightly forward. The points of origin of the main branches of the external carotid in the neck are all related to the tip of the greater cornu of the hyoid bone as follows: 1. The superior thyroid, immediately below it. 2. The lingual, on a level with it. 3. The facial. And 4. The occipital, a little above and behind it. The subclavian artery is indicated on the surface by a curved line, convex upward, from the sternoclavicular articulation to the middle of the clavicle. The highest point of the convexity is from 1 to 3 centimeters above the clavicle. Veins. The surface marking for the internal jugular vein is slightly lateral and parallel to that for the common carotid artery. The position of the external jugular vein is marked out by a line from the angle of the mandible to the middle of the clavicle. A point on this line about 4 centimeters above the clavicle indicates the spot where the vein pierces the deep fascia. The line of the anterior jugular vein begins close to the symphysis menti, runs downward parallel with and a little to one side of the middle line, and, at a variable distance above the jugular notch, turns lateralward to the external jugular. Nerves. The facial nerve, at its exit from the stylomastoid foramen, is situated about 2.5 centimeters from the surface, opposite the middle of the anterior border of the mastoid process. A horizontal line from this point to the ramus of the mandible overlies the stem of the nerve. To mark the site of the accessory nerve, a line is drawn from the angle of the mandible to a point on the anterior border of sternocleidomastoideus, about 3 to 4 centimeters below the apex of the mastoid process, or to the midpoint of the posterior border of the muscle. The line is continued across the posterior triangle to trapezius. The cutaneous branches of the cervical plexus, as they emerge from the posterior border of sternocleidomastoideus, may be indicated as follows. The lesser occipital begins immediately above the midpoint of the border and runs along the border to the scalp. The great auricular and cervical cutaneous both start from the middle of the border, the former running upward toward the lobule of the auricula, the latter crossing sternocleidomastoideus at right angles to its long axis. The supraclavicular nerves emerge from immediately below the middle of the posterior border and run down over the clavicle. The phrenic nerve begins at the level of the middle of the thyroid cartilage and runs behind the clavicle about midway between the anterior and posterior borders of sternocleidomastoideus. The upper border of the brachial plexus is indicated by a line from the side of the cricoid cartilage to the middle of the clavicle. Submaxillary gland. On either side of the neck, the superficial
Section 50 of Gray's Anatomy, Part 5. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information, or to volunteer, please visit LibriVox.org. Recording by David Lawrence. Anatomy of the Human Body, Part 5, by Henry Gray. 50. Surface Anatomy. Surface markings of back. 3. Surface anatomy of the back. Bones. The only subcutaneous parts of the vertebral column are the apices of the spinous processes. These are distinguishable at the bottom of a furrow which runs down the middle line of the back, from the external occipital protuberance to the middle of the sacrum. In the cervical region, the furrow is broad and ends below in a conspicuous projection caused by the spinous processes of the 7th cervical and 1st thoracic vertebrae. Above this, the spinous process of the 6 cervical vertebrae sometimes form a projection. The other cervical spinous processes are sunken, but that of the axis can be felt. In the thoracic region, the furrow is shallow and during stooping disappears, and then the spinous processes become more or less visible. The markings produced by them are small and close together. In the lumbar region, the furrow is deep, and the situations of the spinous processes are frequently indicated by little pits or depressions, especially when the muscles in the loins are well developed. In the sacral region, the furrow is shallower, presenting a flattened area which ends below at the most prominent part of the dorsal surface of the sacrum, i.e., the spinous process of the third sacral vertebra. At the bottom of the sacral furrow, the irregular dorsal surface of the bone may be felt, and below this, in the deep groove running to the anus, the coccyx. The only other portions of the vertebral column which can be felt from the surface are the transverse processes of the first, sixth, and seventh cervical vertebrae. Muscles. The muscles proper of the back are so obscured by those of the upper extremity that they have very little influence on surface form. The splenei, by their divergence, serve to broaden out the upper part of the back of the neck, and produce a fullness in this situation. In the loin, the sacrospinales, bound down by the lumbodorsal fascia, form rounded vertical eminences which determine the depth of the spinal furrow, and taper below to a point on the dorsal surface, the sacrum. The continuations of the sacrospinales in the lower thoracic region form flattened planes which are gradually lost on passing upward. Bony landmarks. In order to identify any particular spinous process, it is customary to count from the prominence caused by the seventh cervical and first thoracic. Of these the latter is the most prominent. The root of the spine of the scapula is on a level with the tip of the spinous process of the third thoracic vertebrae, and the inferior angle with that of the seventh. The highest point of the iliac crest is on a level with the spinous process of the fourth lumbar, and the posterior superior iliac spine with that of the second sacral. The transverse process of the atlas is about 1 centimeter below and in front of the apex of the mastoid process. The transverse process of the sixth cervical vertebra is opposite the cricoid cartilage. Below it is the transverse process of the seventh and occasionally a cervical rib. Medulla spinalis. The position of the lower end of the medulla spinalis varies slightly with the movements of the vertebral column, but in the adult in the upright posture it is usually at the level of the spinous process of the second lumbar vertebra. At birth it lies at the level of the fourth lumbar. The subdural and subarachnoid cavities end below opposite the spinous process of the third sacral vertebra.
Section 51 of Gray's Anatomy, Part 5. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Reading by Bologna Times. Anatomy of the Human Body, Part 5, by Henry Gray. Surface Anatomy and Surface Markings of Thorax. 5. Surface Anatomy of the Thorax. Bones. The skeleton of the thorax is to a very considerable extent covered by muscles, so that in the strongly developed muscular subject it is for the most part concealed. In the emaciated subject, however, the ribs, especially in the lower and lateral regions, stand out as prominent ridges with the sunken intercostal spaces between them. In the middle line, in front, the superficial surface of the sternum can be felt throughout its entire length at the bottom of a furrow, the sternal furrow, situated between the pectoralis majoris. These muscles overlap the anterior surface somewhat, so that the whole width of the sternum is not subcutaneous, and this overlapping is greatest opposite the middle of the bone. The furrow, therefore, is wide at its upper and lower parts, but narrow in the middle. At the upper border of the manubrium sterni is the jugular notch. The lateral parts of this notch are obscured by the tendinous origins of the sternocleidomastoidea, which appear as oblique cords narrowing and deepening the notch. Lower down on the subcutaneous surface is a well-defined transverse ridge, the sternal angle. It denotes the junction of the manubrium and body. From the middle of the sternum, the sternal furrow spreads out and ends at the junction of the body with the xiphoid process. Immediately below this is the infrasternal notch, between the sternal ends of the seventh costal cartilages, and below the notch is a triangular depression, the epigastric fossa, in which the xiphoid process can be felt. On either side of the sternum, the costal cartilages and ribs on the front of the thorax are partly obscured by the pectoralis major, through which, however, they can be felt as ridges with yielding intervals between them, corresponding to the intercostal spaces. Of these spaces, that between the second and third ribs is the widest. The next two are somewhat narrower, and the remainder, with the exception of the last two, are comparatively narrow. Below the lower border of the pectoralis major on the front of the chest, the broad flat outlines of the ribs as they descend, and the more rounded outlines of the costal cartilages are often visible. The lower boundary of the front of the thorax, which is most plainly seen by bending the body backward, is formed by the xiphoid process, the cartilages of the 7th, 8th, 9th, and 10th ribs, and the ends of the cartilages of the 11th and 12th ribs. On either side of the thorax, from the axilla downward, the flattened external surfaces of the ribs may be defined. Although covered by muscles, all the ribs, with the exception of the first, can generally be followed without difficulty over the front and sides of the thorax. The first rib, being almost completely covered by the clavicle, can only be distinguished in a small portion of its extent. At the back, the angles of the ribs lie on a slightly marked oblique line on either side of, and some distance from, the spinous processes of the vertebrae. The line diverges somewhat as it descends, and lateral to it is a broad convex surface caused by the projection of the ribs beyond their angles. Over this surface, except where covered by the scapula, the individual ribs can be distinguished. Muscles. The surface muscles covering the thorax belong to the musculature of the upper extremity, and will be described in that section. There is, however, an area of practical importance bounded by these muscles. It is limited above by the lower border of trapezius, below by the upper border of latissimus dorsi, and laterally by the vertebral border of the scapula. The floor is partly formed by rhomboideus major. If the scapula be drawn forward by folding the arms across the chest, and the trunk bent forward, parts of the 6th and 7th ribs, and the interspace between them, become subcutaneous and available for auscultation. The space is therefore known as the triangle of auscultation. Mamma. The size of the mamma is subject to great variations. In the adult nulliparous female, it extends vertically from the 2nd to the 6th rib, and transversely from the side of the sternum to the mid-axillary line. In the male, and in the nulliparous female, the mammary papilla is situated in the 4th interspace, about 9 or 10 centimeters from the middle line, or 2 centimeters from the costochondral junction. 6. Surface markings of the thorax. Bony landmarks. The second costal cartilage, corresponding to the sternal angle, is so readily found that it is used as a starting point from which to count the ribs. The lower border of the pectoralis major at its attachment corresponds to the fifth rib. The uppermost visible digitation of serratus anterior indicates the sixth rib. The jugular notch is in the same horizontal plane as the lower border of the body of the second thoracic vertebra. The sternal angle is at the level of the fifth thoracic vertebra, while the junction between the body and xiphoid process of the sternum corresponds to the fibrocartilage between the ninth and 10th thoracic vertebrae. The influence of the obliquity of the ribs on horizontal levels in the thorax is well shown by the following line. Quote, "If a horizontal line be drawn around the body at the level of the inferior angle of the scapula, while the arms are at the sides, the line would cut the sternum in front between the fourth and fifth ribs, the fifth rib in the nipple line, and the ninth rib at the vertebral column." Unquote. Treves. Diaphragm. The shape and variations of the diaphragm as seen by skiography have already been described. Page 407. Surface lines. For clinical purposes and for convenience of description, the surface of the thorax has been mapped out by arbitrary lines. On the front of the thorax, the most important vertical lines are the midsternal, the middle line of the sternum, and the mammary, or better, midclavicular, which runs vertically downward from a point midway between the center of the jugular notch and the tip of the acromion. This latter line, if prolonged, is practically continuous with the lateral line on the front of the abdomen. Other vertical lines on the front of the thorax are the lateral sternal along the sternal margin, and the peristernal midway between the lateral sternal and the mammary. On either side of the thorax, the anterior and posterior axillary lines are drawn vertically from the corresponding axillary folds. The mid-axillary line runs downward from the apex of the axilla. On the posterior surface of the thorax, the scapular line is drawn vertically through the inferior angle of the scapula. Pleurae. The lines of reflection of the pleurae can be indicated on the surface. On the right side, the line begins at the sternoclavicular articulation and runs downward and medialward to the midpoint of the junction between the manubrium and body of the sternum. It then follows the midsternal line to the lower end of the body of the sternum, or onto the xiphoid process, where it turns lateralward and downward across the seventh sternocostal articulation. It crosses the eighth costochondral junction in the mammary line, the 10th rib in the mid-axillary line, and is prolonged thence to the spinous process of the 12th thoracic vertebra. On the left side, beginning at the sternoclavicular articulation, it reaches the midpoint of the junction between the manubrium and body of the sternum, and extends down the midsternal line in contact with that of the opposite side to the level of the fourth costal cartilage. It then diverges lateralward and is continued downward slightly lateral to the sternal border as far as the sixth costal cartilage. Running downward and lateralward from this point, it crosses the seventh costal cartilage, and from this onward it is similar to the line on the right side, but at a slightly lower level. Lungs. The apex of the lung is situated in the neck above the medial third of the clavicle. The height to which it rises above the clavicle varies very considerably, but is generally about 2.5 centimeters. It may, however, extend as high as 4 or 5 centimeters, or, on the other hand, may scarcely project above the level of this bone. In order to mark out the anterior borders of the lungs, a line is drawn from each apex point 2.5 centimeters above the clavicle and rather nearer the anterior than the posterior border of sternocleidomastoideus, downward and medialward across the sternoclavicular articulation and manubrium sterni, until it meets, or almost meets, its fellow of the other side at the midpoint of junction between the manubrium and body of the sternum. From this point the two lines run downward, practically along the midsternal line, as far as the level of the fourth costal cartilages. The continuation of the anterior border of the right lung is marked by a prolongation of its line vertically downward to the level of the sixth costal cartilage, and then it turns lateralward and downward. The line on the left side curves lateralward and downward across the fourth sternocostal articulation, to reach the peristernal line at the fifth costal cartilage, and then turns medialward and downward to the sixth sternocostal articulation. In the position of expiration, the lower border of the lung may be marked by a slightly curved line with its convexity downward, from the sixth sternocostal junction to the 10th thoracic spinous process. This line crosses the mid-clavicular line at the sixth and the mid-axillary line at the eighth rib. The posterior borders of the lungs are indicated by lines drawn from the level of the spinous process of the seventh cervical vertebra, down either side of the vertebral column, across the costal vertebral joints, as low as the spinous process of the 10th thoracic vertebra. The position of the oblique fissure in either lung can be shown by a line drawn from the spinous process of the second thoracic vertebra around the side of the thorax to the sixth rib in the mid-clavicular line. This line corresponds roughly to the line of the vertebral border of the scapula when the hand is placed on the top of the head. The horizontal fissure in the right lung is indicated by a line drawn from the midpoint of the preceding, or from the position where it cuts the mid-axillary line to the mid-sternal line at the level of the fourth costal cartilage. Trachea. This may be marked out on the back by a line from the spinous process of the sixth cervical to that of the fourth thoracic vertebra where it bifurcates. From its bifurcation the two bronchi are directed downward and lateralward. In front, the point of bifurcation corresponds to the sternal angle. Esophagus. The extent of the esophagus may be indicated on the back by a line from the sixth cervical to the level of the ninth thoracic spinous process, 2.5 centimeters to the left of the middle line. Heart. The outline of the heart in relation to the front of the thorax can be represented by a quadrangular figure. The apex of the heart is first determined either by its pulsation or as a point in the fifth interspace, 9 centimeters to the left of the midsternal line. The other 3 points are a. the seventh right sternocostal articulation, b. a point on the upper border of the third right costal cartilage, 1 centimeter from the right lateral sternal line, c. a point on the lower border of the second left costal cartilage, 2.5 centimeters from the left lateral sternal line. A line joining the apex point, A, and traversing the junction of the body of the sternum with the xiphoid process represents the lowest limit of the heart, its acute margin. The right and left borders are represented respectively by lines joining A to B and the apex to C. Both lines are convex lateralward, but the convexity is more marked on the right, where its summit is 4 centimeters distant from the midsternal line opposite the fourth costal cartilage. A portion of the area of the heart thus mapped out is uncovered by lung and therefore gives a dull note on percussion. The remainder being overlapped by lung gives a more or less resonant note. The former is known as the area of superficial cardiac dullness, the latter as the area of deep cardiac dullness. The area of superficial cardiac dullness is somewhat triangular. From the apex of the heart, two lines are drawn to the midsternal line, one to the level of the fourth costal cartilage, the other to the junction between the body and xiphoid process. The portion of the midsternal line between these points is the base of the triangle. Latham lays down the following rule as a sufficient practical guide for the definition of the area of superficial dullness. Quote, "Make a circle of 2 inches in diameter around a point midway between the nipple and the end of the sternum." Unquote. The coronary sulcus can be indicated by a line from the 3rd left to the 6th right sternocostal joint. The anterior longitudinal sulcus is a finger's breadth to the right of the left margin of the heart. The position of the various orifices is as follows. The pulmonary orifice is situated in the upper angle of the 3rd left sternocostal articulation. The aortic orifice is a little below and medial to this, close to the articulation. The left atrioventricular opening is opposite the 4th costal cartilage, and rather to the left of the midsternal line. The right atrioventricular opening is a little lower, opposite the 4th interspace of the right side. The lines indicating the atrioventricular openings are slightly below and parallel to the line of the coronary sulcus. Arteries. The line of the ascending aorta begins slightly to the left of the midsternal line, opposite the 3rd costal cartilage, and extends upward and to the right to the upper border of the 2nd right costal cartilage. The beginning of the aortic arch is indicated by a line from this latter point to the midsternal line about 2.5 centimeters below the jugular notch. The point on the midsternal line is opposite the summit of the arch, and a line from it to the right sternoclavicular articulation represents the site of the innominate artery, while another line from a point slightly to the left of it and passing through the left sternoclavicular articulation indicates the position of the left common carotid artery in the thorax. The internal mammary artery descends behind the first 6 costal cartilages about 1 centimeter from the lateral sternal line. Veins. The line of the right innominate vein crosses the right sternoclavicular joint and the upper border of the first right costal cartilage about 1 centimeter from the lateral sternal line. That of the left innominate vein extends from the left sternoclavicular articulation to meet the right at the upper border of the first right costal cartilage. The junction of the two lines indicates the origin of the superior vena cava, the line of which is continued vertically down to the level of the 3rd right costal cartilage. The end of the inferior vena cava is situated opposite the upper margin of the 6th right
Section 52 of Gray's Anatomy, Part 5. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by David Lawrence. Anatomy of the Human Body, Part 5 by Henry Gray. Surface Anatomy of Abdomen. Skin. The skin of the front of the abdomen is thin. In the male it is often thickly hair-clad, especially toward the lower part of the middle line. In the female the hairs are confined to the pubes. Just below the line of the iliac crest, especially marked in fat subjects, is a shallow groove termed the iliac furrow, while in the site of the inguinal ligament A sharper fold, known as the fold of the groin, is easily distinguishable. After distension of the abdomen from pregnancy or other causes, the skin commonly presents transverse white lines, which are quite smooth, being destitute of papillae. These are known as the strata gravidarum, or strata albicantes. The linea nigra of pregnancy is often seen as a pigmented brown streak in the middle line between the umbilicus and symphysis pubis. In the middle line of the front of the abdomen is a shallow furrow which extends from the junction between the body of the sternum with the xiphoid process to a short distance between the umbilicus. It corresponds to the linea alba. The umbilicus is situated in the middle line, but varies in position as regards to its height. In an adult subject it is always placed above the middle point of the body, and in a normal, well-nourished subject it is from 2 to 2.5 centimeters above the level of the tubercles of the iliac crests. Bones. The bones in relation with the surface of the abdomen are 1. The lower part of the vertebral column and the lower ribs, and 2. The pelvis, the former having already been described. The latter will be considered with the lower limb. Muscles. The only muscles of the abdomen which have any considerable influence on surface form are the obliquus externus and the rectus. The upper digitations of origin of obliquus externus are well marked in a muscular subject, interdigitating with those in serratus anterior. The lower digitations are covered by the border of latissimus dorsi and are not visible. The attachment of the obliqui externus and internus to the crest of the ilium forms a thick oblique roll which determines the iliac furrow. Sometimes on the front of the lateral region of the abdomen an undulating line marks the passing of the muscular fibers of the obliquus externus into its aponeurosis. The lateral markings of the obliquus externus is separated from that of the latissimus dorsi by a small triangular interval, the lumbar triangle, the base of which is formed by the iliac crest, and its floor by obliquus externus. The lateral margin of rectus abdominis is indicated by the linea semilunaris, which may be exactly defined by putting the muscle into action. The surface of the rectus presents 3 transverse furrows, the tendinous inscriptions. The upper 2 of these, viz., one opposite or a little below the tip of the xiphoid process, and the other midway between this point and the umbilicus, are usually well marked. The third, opposite the umbilicus, is not so distinct. Between the 2 recti, the linea alba can be palpated from the xiphoid process to a point just below the umbilicus. It is represented by a distinct dip between the muscles. Beyond this the muscles are in apposition. Vessels. In thin subjects the pulsation of the abdominal aorta can be readily felt by making deep pressure in the middle line above the umbilicus. Viscera. Under normal conditions the various portions of the digestive tube cannot be identified by simple palpation. Peristalsis of the coils of small intestine can be observed in some persons with extremely thin abdominal walls when some degree of constipation exists. In cases of constipation it is sometimes possible to trace portions of the great intestine by feeling the fecal masses within the gut. In thin persons with relaxed abdominal walls, the iliac colon can be felt in the left iliac region, rolling under the fingers when empty, and forming a distinct tumor when distended. The greater part of the liver lies under cover of the lower ribs and their cartilages, but in the epigastric fossa it comes in contact with the abdominal wall. The position of the liver varies according to the posture of the body. In the erect posture in the adult male, the edge of the liver projects about 1 centimeter below the lower margin of the right costal cartridges, and its inferior margin can often be felt in this situation if the abdominal wall is thin. In the supine position, the liver recedes above the margin of the ribs and cannot then be detected by the finger. In the prone position, it falls forward and is then generally palpable in a patient with loose and lax abdominal walls. Its position varies with the respiratory movements. During a deep inspiration, it descends below the ribs. In expiration, it is raised. Pressure from without, as in tight lacing, by compressing the lower part of the chest, displaces the liver considerably, its interior edge frequently extending as low as the crest of the ilium. Again, its position varies greatly with the state of the stomach and intestines. When these are empty, the liver descends. When they are distended, it is pushed upward. The pancreas can sometimes be felt in emaciated subjects when the stomach and colon are empty, by making deep pressure in the middle line about 7 or 8 centimeters above the umbilicus. The kidneys, being situated at the back of the abdominal cavity and deeply placed, cannot be palpated unless enlarged or misplaced.
Section 53 of Gray's Anatomy, Part 5. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by John T. Coos, John K. Thomas. Anatomy of the Human Body, Part 5, by Henry Gray. 8. Surface markings of the abdomen. Bony landmarks. Above, the chief bony markings are the xiphoid process, the lower 6 costal cartilages, and the anterior ends of the lower 6 ribs. The junction between the body of the sternum and the xiphoid process is on the level of the 10th thoracic vertebra. Below, the main landmarks are the symphysis, pubis, and the pubic crest and tubercle, the anterior superior iliac spine, and the iliac crest. Muscles. The rectus lies between the linea alba and the linea semilunaris. The former is indicated by the middle line, the latter by a curved line, convex lateralward, from the tip of the cartilage of the 9th rib to the pubic tubercle. At the level of the umbilicus, the linea semilunaris is about 7 centimeters from the middle line, the line indicating the junction of the muscular fibers of obliquus externus with its aponeurosis extends from the tip of the 9th costal cartilage to a point just medial to the anterior superior iliac spine. The umbilicus is at the level of the fibrocartilage between the 3rd and 4th lumbar vertebrae. The subcutaneous inguinal ring is situated 1 centimeter above and lateral to the pubic tubercle. The abdominal inguinal ring lies 1 to 2 centimeters above the middle of the inguinal ligament. The position of the inguinal canal is indicated by a line joining these 2 points. Surface lines. For convenience of description of the viscera and of reference to morbid conditions of the contained parts, the abdomen is divided into 9 regions by imaginary planes, 2 horizontal and 2 sagittal, the edges of the planes being indicated by lines drawn on the surface of the body. In the older method, the upper or subcostal horizontal line encircles the body at the level of the lowest points of the 10th costal cartilages. The lower or intertubercular is a line carried through the highest points of the iliac crest seen from the front, i.e., through the tubercles on the iliac crests about 5 centimeters behind the anterior superior spines. An alternative method is that of Addison, who adopts the following lines. 1. An upper transverse, the transpyloric, halfway between the jugular notch and the upper border of the symphysis pubis. This indicates the margin of the transpyloric plane, which in most cases cuts through the pylorus, the tips of the 9th costal cartilages, and the lower border of the first lumbar vertebra. 2. A lower transverse line midway between the upper transverse and the upper border of the symphysis pubis. This is termed the transtubercular, since it practically corresponds to that passing through the iliac tubercles. Behind, its plane cuts the body of the 5th lumbar vertebra. By means of these horizontal planes, the abdomen is divided into 3 zones named from above: the subcostal, umbilical, and hypogastric zones. Each of these is further subdivided into 3 regions by the 2 sagittal planes, which are indicated on the surface by a right and left lateral line drawn vertically through points halfway between the anterior superior iliac spines and the middle line. The middle region of the upper zone is called epigastric, and the 2 lateral regions, the right and left, hypochondriac. The central region of the middle zone is the umbilical, and the 2 lateral regions, the right and left lumbar. The middle region of the lower zone is the hypogastric or pubic, and the lateral are the right and left iliac or inguinal. The middle regions, viz. Epigastric, umbilical, and pubic, can each be divided into right and left portions by the middle line. In the following description of the viscera, the regions marked out by Addison's lines are those referred to. Stomach. The shape of the stomach is constantly undergoing alteration. It is affected by the particular phase of the process of gastric digestion, by the state of the surrounding viscera, and by the amount and character of its contents. Its position also varies with that of the body, so that it is impossible to indicate it on the surface with any degree of accuracy. The measurements given refer to a moderately filled stomach with the body in the supine position. The cardiac orifice is opposite the 7th costal cartilage, about 2.5 centimeters from the side of the sternum. It corresponds to the level of the 10th thoracic vertebra. The pyloric orifice is on the transpyloric line about 1 centimeter to the right of the middle line, or alternately 5 centimeters below the 7th right sternocostal articulation. It is at the level of the first lumbar vertebra. A curved line, convex downward and to the left, joining these points indicates the lesser curvature. In the left lateral line, the fundus of the stomach reaches as high as the 5th interspace, or the 6th costal cartilage, a little below the apex of the heart. To indicate the greater curvature, a curved line is drawn from the cardiac orifice to the summit of the fundus, thence downward and to the left, finally turning medialward to the pyloric orifice, but passing on its way through the intersection of the left lateral with the transpyloric line. The portion of the stomach which is in contact with the abdominal wall can be represented roughly by a triangular area the base of which is formed by a line drawn from the tip of the 10th left costal cartilage to the tip of the 9th right cartilage, and the sides by 2 lines drawn from the end of the 8th left costal cartilage to the ends of the base line. A space of some clinical importance, the space of Traub, overlies the stomach and may be thus indicated. It is semilunar in outline and lies within the following boundaries: the lower edge of the left lung, the anterior border of the spleen, the left costal margin, and the inferior margin of the left lobe of the liver. Duodenum. The superior part is horizontal and extends from the pylorus to the right lateral line. The descending part is situated medial to the right lateral line, from the transpyloric line to a point midway between the transpyloric and transtubercular lines. The horizontal part runs with a slight upward slope from the end of the descending part to the left of the middle line. The ascending part is vertical and reaches the transpyloric line, where it ends in the duodenojejunal flexure, about 2.5 centimeters to the left of the middle line. Small intestine. The coils of the small intestine occupy the front of the abdomen. For the most part, the coils of the jejunum are situated on the left side, i.e., in the left lumbar and iliac regions, and in the left half of the umbilical region. The coils of the ilium lie toward the right in the right lumbar and iliac regions. In the right half of the umbilical region and in the hypogastric region, a portion of the ilium is within the pelvis. The end of the ilium, i.e. the iliocolic junction, is slightly below and medial to the intersection of the right lateral and transtubercular lines. Cecum and vermiform process. The cecum is in the right iliac and hypogastric regions. Its position varies with its degree of distension, but the midpoint of a line draws from the right anterior superior iliac spine to the upper margin of the symphysis pubis will mark approximately the middle of its lower border. The position of the base of the vermiform process is indicated by a point on the lateral line, on a level with the anterior superior iliac spine. Ascending colon. The ascending colon passes upward through the right lumbar region, lateral to the right lateral line. The right colic flexure is situated in the upper and right angle of intersection of the subcostal and right lateral lines. Transverse colon. The transverse colon crosses the abdomen on the confines of the umbilical and epigastric regions, its lower border being on a level slightly above the umbilicus, its upper border just below the great curvature of the stomach. Descending colon. The left colic flexure is situated in the upper left angle of the intersection between the left lateral and transpyloric lines. The descending colon courses down through the left lumbar region, lateral to the left lateral line, as far as the iliac crest. Iliac colon. The line of the iliac colon is from the end of the descending colon to the left lateral line at the left of the anterior superior iliac spine. Liver. The upper limit of the right lobe of the liver in the middle line is at the level of the junction between the body of the sternum and the xiphoid process. On the right side, the line must be carried upward as far as the 5th costal cartilage in the mammary line, and then downward to reach the 7th rib at the side of the thorax. The upper limit of the left lobe can be defined by continuing this line downward and to the left to the sixth costal cartilage 5 centimeters from the middle line. The lower limit can be indicated by a line drawn 1 centimeter below the lower margin of the thorax on the right side as far as the 9th costal cartilage, thence obliquely upward to the 8th left costal cartilage, crossing to the middle line just above the transpyloric plane, and finally, with a slight left convexity to the end of the line indicating the upper limit. According to Birmingham, the limits of the normal liver may be marked out on the surface of the body in the following manner. Take 3 points. A. 1.25 centimeters below the right nipple. B. 1.25 centimeters below the tip of the 10th rib. C. 2.5 centimeters below the left nipple. Join A and C by a line slightly convex upward, A and B by a line slightly convex lateralward, and B and C by a line slightly convex downward. The fundus of the gallbladder approaches the surface behind the anterior end of the 9th right costal cartilage, close to the lateral margin of the rectus abdominis. Pancreas, figure 1225. The pancreas lies in front of the second lumbar vertebra. Its head occupies the curve of the duodenum and is therefore indicated by the same lines as that viscus. Its neck corresponds to the pylorus. Its body extends along the transpyloric line, the bulk of it lying above this line to the tail, which is in the left hypochondriac region, slightly to the left of the lateral line and above the transpyloric. Spleen. To map out the spleen, the 10th rib is taken as representing its long axis. Vertically, it is situated between the upper border of the 9th and the lower border of the 11th ribs. The highest point is 4 centimeters from the middle line of the back at the level of the tip of the 9th thoracic spinous process. The lowest point is in the mid-axillary line at the level of the first lumbar spinous process. Kidneys. The right kidney usually lies about 1 centimeter lower than the left, but for practical purposes, similar surface markings are taken for each. On the front of the abdomen, the upper pole lies midway between the plane of the lower end of the body of the sternum and the transpyloric plane, 5 centimeters from the middle line. The lower pole is situated between the transpyloric and intertubular planes, 7 centimeters from the middle line. The hilum is on the transpyloric plane, 5 centimeters from the middle line. Round these 3 points, a kidney-shaped figure 4 centimeters to 5 centimeters broad is drawn, 2/3 of which lies medial to the lateral line. To indicate the position of the kidney from the back, the parallelogram of Morris is used. 2 vertical lines are drawn. The first 2.5 centimeters, the second 9.5 centimeters from the middle line. The parallelogram is completed by 2 horizontal lines drawn respectively at the levels of the tips of the spinous process of the 11th thoracic and the lower border of the spinous process of the 3rd lumbar vertebra. The hilum is 5 centimeters from the middle line at the level of the spinous process of the 1st lumbar vertebra. Ureters. On the front of the abdomen, the line of the ureter runs from the hilum of the kidney to the pubic tubercle. On the back, from the hilum vertically downward, passing practically through the posterior superior iliac spine. Vessels. The inferior epigastric artery, can be marked out by a line from a point midway between the anterior superior iliac spine and the pubic symphysis to the umbilicus. This line also indicates the lateral boundary of Hesselbach's triangle, an area of importance in connection with inguinal hernia. The other boundaries are the lateral edge of rectus abdominis and the medial half of the inguinal ligament. The line of the abdominal aorta begins in the middle line about 4 centimeters above the transpyloric line and extends to a point 2 centimeters below and to the left of the umbilicus, or more accurately, to a point 2 centimeters to the left of the middle line, on a line which passes through the highest points of the iliac crests. The point of termination of the abdominal aorta corresponds to the level of the fourth lumbar vertebra, a line drawn from it to a point midway between the anterior superior iliac spine and the symphysis pubis indicates the common and external iliac arteries. The common iliac is represented by the upper third of this line, the external iliac by the remaining 2/3. Of the larger branches of the abdominal aorta, the celiac artery is 4 centimeters, the superior mesenteric 2 centimeters above the transpyloric line. The renal arteries are 2 centimeters below the same line. The inferior mesenteric artery is 4 centimeters above the bifurcation of the abdominal aorta. Nerves. The thoracic nerves on the anterior abdominal wall are represented by lines continuing those of the bony ribs. The termination of the 7th nerve is at the level of the xiphoid process. The 10th reaches the vicinity of the umbilicus. The 12th ends about midway between the umbilicus and the upper border of the symphysis pubis. The first lumbar is parallel to the thoracic nerves. Its iliohypogastric branch becomes cutaneous above the subcutaneous inguinal ring. Section 54 of Gray's Anatomy, Part 5. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information, or to volunteer, please visit LibriVox.org. Recording by John K. Thomas, John Coos, Fern. Anatomy of the Human Body, Part 5, by Henry Gray. 9. Surface anatomy of the perineum. Skin. In the middle line of the posterior part of the perineum, and about 4 centimeters in front of the tip of the coccyx, is the anal orifice. The junction of the mucous membrane of the anal canal with the skin of the perineum is marked by a white line, which indicates also the line of contact of the external and internal sphincters. In the anterior part of the perineum, the external genital organs are situated. The skin covering the scrotum is rough and corrugated, but over the penis it is smooth. Extending forward from the anus onto the scrotum and penis is a median ridge, which indicates the scrotal raphe. In the female are seen the skin reduplications forming the labia majora and minora laterally, the frenulum of the labia behind, and the pubis of the clitoris in front. Still more anteriorly is the mons pubis. Bones. In the anterolateral boundaries of the perineum, the whole outline of the pubic arch can be readily traced, ending in the ischial tuberosities. Behind, in the middle line, is the tip of the coccyx. Muscles and ligaments. The margin of the gluteus maximus forms the posterolateral boundary, and in thin subjects, by pressing deeply, the sacrotuberous ligament can be felt through the muscle. The only other muscles influencing surface form are the ischiocavernosus, covering the crus-penis, which lies on the side of the pubic arch, and the sphincter ani externus, which, in action, closes the anal orifice and causes a puckering of the skin around it. 10. Surface markings of the perineum. A line drawn transversely across, in front of the ischial tuberosities, divides the perineum into a posterior or rectal, and an anterior or urogenital triangle. This line passes through the central point of the perineum, which is situated about 2.5 centimeters in front of the center of the anal aperture, or, in the male, midway between the anus and the reflection of the skin onto the scrotum. Rectum and anal canal. A finger inserted through the anal orifice is grasped by the sphincter ani externus, passes into the region of the sphincter ani internus, and higher up encounters the resistance of the puborectalis. Beyond this, it may reach the lowest of the transverse rectal folds. In front, the urethral bulb and membranous part of the urethra are first identified, and then about 4 centimeters above the anal orifice, the prostate is felt. Beyond this, the vesiculae seminals, if enlarged, and the fundus of the bladder, when distended, can be recognized. On either side is the ischiorectal fossa. Behind are the anococcygeal body, the pelvic surfaces of the coccyx and lower end of the sacrum, and the sacrospinous ligaments. In the female, the posterior wall and fornix of the vagina and the cervix and body of the uterus can be felt in front, while somewhat laterally the ovaries can just be reached. Male urogenital organs. The corpora cavernosa penis can be followed backward to the crura, which are attached to the sides of the pubic arch. The glans penis, covered by the pubis, and the external urethral orifice can be examined, and the course of the urethra traced along the under surface of the penis to the bulb, which is situated immediately in front of the central point of the perineum. Through the wall of the scrotum on either side of the testis can be palpated. It lies toward the back of the scrotum, and along its posterior border the epididymis can be felt. Passing upward along the medial side of the epididymis is the spermatic cord, which can be traced upward to the subcutaneous inguinal ring. By means of a sound, the general topography of the urethra and bladder can be investigated. With the urethroscope, the interior of the urethra can be illuminated and viewed directly. With the cystoscope, the interior of the bladder is in a similar manner illuminated for visual examination. In the bladder, the main points to which attention is directed are the trigone, the torus uretericus, the plicae uretericae, and the openings of the ureters and urethra. Female urogenital organs. In the pudental cleft between the labia minora and the openings of the vagina and urethra. In the virgin, the vaginal opening is partly closed by the hymen, After coitus, the remains of the hymen are represented by the carunculae hymenals. Between the hymen and the frenulum of the labia is the fossa navicularis, while in the groove between the hymen and the labium minus on either side, the small opening of the greater vestibular Bartholin's gland can be seen. These glands, when enlarged, can be felt on either side of the posterior part of the vaginal orifice. By inserting a finger into the vagina, the following structures can be examined through its wall. Behind, from below upward, are the anal canal, the rectum, and the rectuterine excavation. Projecting into the roof of the vagina is the vaginal portion of the cervix uteri with the external uterine orifice. In front of and behind the cervix, the anterior and posterior vaginal fornices respectively can be examined. With the finger in the vagina and the other hand on the abdominal wall, the whole of the cervix and body of the uterus, the uterine tubes, and the ovaries can be palpated. If a speculum be introduced into the vagina, the walls of the passage, the vaginal portion of the cervix, and the external uterine orifice can be exposed for visual examination. The external urethral orifice lies in front of the vaginal opening. The angular gap in which it is situated between the two converging labia minora is termed the vestibule. The urethral canal in the female is very dilatable and can be explored with the finger. About 2.5 centimeters in front of the external orifice of the urethra are the glands and prepuce of the clitoris, and still farther forward is the mons pubis. End of section 54. Recording by John T.K.
Section 55 of Gray's Anatomy, Part 5. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Anatomy of the Human Body, Part 5, by Henry Gray. Surface Anatomy of Upper Extremity, Part 1. Skin. The skin covering the shoulder and arm is smooth and very movable on the underlying structures. In the axilla there are numerous hairs and many sudoriferous and sebaceous glands. Over the medial side and front of the forearm, the skin is thin and smooth, and contains few hairs but many sudoriferous glands. Over the lateral side and back of the arm and forearm it is thicker, denser, and contains more hairs but fewer sudoriferous glands. In the region of the olecranon it is thick and rough, and is very loosely connected to the underlying tissue, so that it falls into transverse wrinkles when the forearm is extended. At the front of the wrist, there are 3 transverse furrows in the skin. They correspond, respectively, from above downward, to the positions of the styloid process of the ulna, the wrist joint, and the midcarpal joint. The skin of the palm of the hand differs considerably from that of the forearm. At the wrist it suddenly becomes hard and dense and covered with a thick layer of epidermis. On the thenar eminence these characteristics are less marked than elsewhere. In spite of its hardness and density, the skin of the palm is exceedingly sensitive and very vascular, but it is destitute of hairs and sebaceous glands. It is tied down by fibrous bands along the lines of flexion of the digits, exhibiting certain furrows of a permanent character. One of these, starting in front of the wrist at the tuberosity of the navicular bone, curves around the thenar eminence and ends on the radial border of the hand a little above the metacarpophalangeal joint of the index finger. A second line begins at the end of the first, and extends obliquely across the palm to reach the ulnar border about the middle of the 5th metacarpal bone. A third line begins at the ulnar border about 2.5 centimeters distal to the end of the second, and extends across the heads of the 5th, 4th, and 3rd metacarpal bones. The proximal segments of the fingers are joined to one another on the volar aspect by folds of skin constituting the web of the fingers. These folds extend across about the level of the centers of the proximal phalanges, and their free margins are continuous with the transverse furrows at the roots of the fingers. Since the web is confined to the volar aspect, the fingers appear shorter when viewed from in front than from behind. Over the fingers and thumb, the skin again becomes thinner, especially at the flexures of the joints where it is crossed by transverse furrows, and over the terminal phalanges. It is disposed on numerous ridges in consequence of the arrangement of the papillae in it. These ridges form, in different individuals, distinctive and permanent patterns which can be used for purposes of identification. The superficial fascia in the palm of the hand is made up of dense fibrofatty tissue which binds the skin so firmly to the palmar aponeurosis that very little movement is permitted between the two. On the back of the hand and fingers, the subcutaneous tissue is lax, so that the skin is freely movable on the underlying parts. Over the interphalangeal joints, the skin is very loose and is thrown into transverse wrinkles when the fingers are extended. Bones. The clavicle can be felt throughout its entire length. The enlarged sternal extremity projects above the upper margin of the sternum at the side of the jugular notch, and from this the body of the bone can be traced lateralward immediately under the skin. The medial part is convex forward, but the surface is partially obscured by the attachments of the sternocleido mastoideus and pectoralis major. The lateral third is concave forward, and ends at the acromion of the scapula in a slight enlargement. The clavicle is almost horizontal when the arm is lying by the side, although in muscular subjects it may incline a little upward at its acromial end, which is on a plane posterior to the sternal end. The only parts of the scapula that are truly subcutaneous are the spine and acromion, but the coracoid process, the vertebral border, the inferior angle, and to a lesser extent the axillary border, can also be readily defined. The acromion and spine are easily recognizable throughout their entire extent, forming with the clavicle the arch of the shoulder. The acromion forms the point of the shoulder. It joins the clavicle at an acute angle, the acromial angle, slightly medial to and behind the tip of the acromion. The spine can be felt as a distinct ridge, marked on the surface as an oblique depression which becomes less distinct and ends in a slight dimple, a little lateral to the spinous processes of the vertebrae. Below this point, the vertebral border can be traced downward and lateralward to the inferior angle, which can be identified although covered by latissimus dorsi. From the inferior angle, the axillary border can usually be traced upward through its thick muscular covering, forming with its enveloping muscles the posterior fold of the axilla. The coracoid process is situated about 2 centimeters below the junction of the intermediate and lateral thirds of the clavicle. It is covered by the anterior border of deltoideus, and thus lies a little lateral to the infraclavicular fossa or depression, which marks the interval between the pectoralis major and deltoideus. The humerus is almost entirely surrounded by muscles, and the only parts which are strictly subcutaneous are small portions of the medial and lateral epicondyles. In addition to these, however, the tubercles and a part of the head of the bone can be felt under the skin and muscles by which they are covered. Of these, the greater tubercle forms the most prominent bony point of the shoulder, extending beyond the acromion. It is best recognized when the arm is lying passive by the side, for if the arm be raised, it recedes under the arch of the shoulder. The lesser tubercle, directed forward, is medial to the greater and separated from it by the intertubercular groove, which can be made out by deep pressure. When the arm is abducted, the lower part of the head of the humerus can be examined by pressing deeply in the axilla. On either side of the elbow joint and just above it are the medial and lateral epicondyles. Of these, the former is the more prominent, but the medial supracondylar ridge passing upward from it is much less marked than the lateral, and as a rule is not palpable. Occasionally, however, the hook-shaped supracondylar process is found on this border. The position of the lateral epicondyle is best seen during semiflexion of the forearm, and is indicated by a depression. From it, the strongly marked lateral supracondylar ridge runs upward. The most prominent part of the ulna, the olecranon, can always be identified at the back of the elbow joint. When the forearm is flexed, the upper quadrilateral surface is palpable, but during extension it recedes into the olecranon fossa. During extension, the upper border of the olecranon is slightly above the level of the medial epicondyle, and nearer to this than to the lateral. When the forearm is fully flexed, the olecranon and the epicondyles form the angles of an equilateral triangle. On the back of the olecranon is a smooth triangular subcutaneous surface, and running down the back of the forearm from the apex of this triangle, the prominent dorsal border of the ulna can be felt in its whole length. It has a sinuous outline and is situated in the middle of the back of the limb above, but below, where it is rounded off, it can be traced to the small subcutaneous surface of the styloid process on the medial side of the wrist. The styloid process forms a prominent tubercle continuous above with the dorsal border and ending below in a blunt apex at the level of the wrist joint. It is most evident when the hand is in a position midway between supination and pronation. When the forearm is pronated, another prominence, the head of the ulna, appears behind and above the styloid process. Below the lateral epicondyle of the humerus, a portion of the head of the radius is palpable. Its position is indicated on the surface by a little dimple, which is best seen when the arm is extended. If the finger be placed in this dimple and the semi-flexed forearm be alternately pronated and supinated, the head of the radius will be felt distinctly rotating in the radial notch. The upper half of the body of the bone is obscured by muscles. The lower half, though not subcutaneous, can be readily examined, and if traced downward is found to end in a lozenge-shaped convex surface on the lateral side of the base of the styloid process. This is the only subcutaneous part of the bone, and from its lower end the apex of the styloid process bends medialward toward the wrist. About the middle of the dorsal surface of the lower end of the radius is the dorsal radial tubercle, best perceived when the wrist is slightly flexed. It forms the lateral boundary of the oblique groove for the tendon of the extensor pollicis longus. On the front of the wrist are two subcutaneous eminences, one on the radial side, the larger and flatter, produced by the tuberosity of the navicular and the ridge on the greater multangular, the other on the ulnar side by the pisiform. The tuberosity of the navicular is distal and medial to the styloid process of the radius, and is most clearly visible when the wrist joint is extended. The ridge on the greater multangular is about 1 centimeter distal to it. The pisiform is about 1 centimeter distal to the lower end of the ulna, and just distal to the level of the styloid process of the radius. It is crossed by the uppermost crease which separates the front of the forearm from the palm of the hand. The rest of the volar surface of the bony carpus is covered by tendons and the transverse carpal ligament and is entirely concealed, with the exception of the hamulus of the hamate bone, which, however, is difficult to define. On the dorsal surface of the carpus only the triangular bone can be clearly made out. Distal to the carpus, the dorsal surfaces of the metacarpal bones, covered by the extensor tendons, except the fifth, are visible only in very thin hands. The dorsal surface of the fifth is, however, subcutaneous throughout almost its whole length. Slightly lateral to the middle line of the hand is a prominence, frequently well marked but occasionally indistinct, formed by the styloid process of the third metacarpal bone. It is situated about 4 centimeters distal to the dorsal radial tubercle. The heads of the metacarpal bones can be plainly seen and felt, rounded in contour and standing out in bold relief under the skin when the fist is clenched. The head of the third is the most prominent. In the palm of the hand, the metacarpal bones are covered by muscles, tendons, and aponeuroses, so that only their heads can be distinguished. The base of the metacarpal bone of the thumb, however, is prominent dorsally, distal to the styloid process of the radius. The body of the bone is easily palpable, ending at the head in a flattened prominence, in front of which are the sesamoid bones. The enlarged ends of the phalanges can be easily felt. When the digits are bent, the proximal phalanges form prominences, which in the joints between the first and second phalanges are slightly hollow, but flattened and square-shaped in those between the second and third. Articulations. The sternoclavicular joint is subcutaneous, and its position is indicated by the enlarged sternal extremity of the clavicle, lateral to the long cord-like sternal head of sternocleidomastoideus. If this muscle be relaxed, a depression between the end of the clavicle and the sternum can be felt, defining the exact position of the joint. The position of the acromioclavicular joint can generally be ascertained by determining the slightly enlarged acromial end of the clavicle, which projects above the level of the acromion. Sometimes this enlargement is so considerable as to form a rounded eminence. The shoulder joint is deeply seated and cannot be palpated. If the forearm be slightly flexed, a curved crease or fold with its convexity downward is seen in front of the elbow, extending from one epicondyle to the other. The elbow joint is slightly distal to the center of the fold. The position of the radiohumeral joint can be ascertained by feeling for a slight groove or depression between the head of the radius and the capitulum of the humerus, at the back of the elbow joint. The position of the proximal radio-ulnar joint is marked on the surface at the back of the elbow by the dimple which indicates the position of the head of the radius. The site of the distal radio-ulnar joint can be defined by feeling for the slight groove at the back of the wrist, between the prominent head of the ulna and the lower end of the radius, when the forearm is in a state of almost complete pronation. Of the 3 transverse skin furrows on the front of the wrist, the middle corresponds fairly accurately with the wrist joint, while the most distal indicates the position of the midcarpal articulation. The metacarpophalangeal and interphalangeal joints are readily available for surface examination. The former are situated just distal to the prominence.
Section 56 of Gray's Anatomy, Part 5. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Jean Luft. Anatomy of the Human Body, Part 5, by Henry Gray. Surface Anatomy of Upper Extremity, Part 2. Muscles. The anterior border of the trapezius presents as a slight ridge running downward and forward from the superior neutral line of the occipital bone to the junction of the intermediate and lateral thirds of the clavicle. The inferior border of the muscle forms an undulating ridge passing downward and medialward from the root of the spine of the scapula to the spinous process of the 12th thoracic vertebra. The lateral border of the latissimus dorsi may be traced when the muscle is in action as a rounded edge starting from the iliac crest and slanting obliquely forward and upward to the axilla, where it takes part with a teres major in forming the posterior axillary fold. The pectoralis major conceals a considerable part of the thoracic wall in front. Its sternal organ presents a border which bounds and determines the width of the sternal furrow. The upper margin is generally well marked medially and forms the medial boundary of a triangular depression, the infraclavicular fossa, which separates the pectoralis major from the deltoideus. It gradually becomes less marked as it approaches the tendon of insertion and is closely blended with the deltoideus. The lower border of pectoralis major forms the rounded anterior axillary fold. Occasionally, a gap is visible between the clavicular and sternal parts of the muscle. When the arm is raised, the lowest slip of origin of pectoralis minor produces a fullness just below the anterior axillary fold and serves to break the sharp outline of the lower border of pectoralis major. The origin of the serratus anterior causes a very characteristic surface marking. When the arm is abducted, the lower 5 or 6 serrations form a zigzag line with a general convexity forward. When the arm is by the side, the highest visible serration is that attached to the 5th rib. The deltoideus, with the prominence of the upper end of the humerus, produces the rounded contour of the shoulder. It is rounded and fuller in front than behind. where it presents a somewhat flattened form. Above, its anterior border presents a slightly curved eminence, which forms the lateral boundary of the infraclavicular fossa. Below, it is closely united with the pectoralis major. Its posterior border is thin, flattened, and scarcely marked above, but is thicker and more prominent below. The insertion of deltoideus is marked by a depression on the lateral side of the middle of the arm. Of the scapular muscles, the only one which influences surface form is the teres major. It assists the latissimus dorsi in forming the thick, rounded posterior axillary fold. When the arm is raised, the chora cobrachialis reveals itself as a narrow elevation emerging from under cover of the anterior axillary fold and running medial to the body of the humerus. On the front and medial aspects of the arm is the prominence of the biceps brachii, bounded on either side by an interior muscular depression. It determines the contour of the front of the arm and extends from the anterior axillary fold to the bend of the elbow. Its upper tendons are concealed by the pectoralis major and deltoideus, and its lower tendon sinks into the antecubital fossa. When the muscle is fully contracted, it presents a globular form, and the lacertus fibrosus attached to its tendon of insertion becomes prominent as a sharp ridge running downward and medialward. On either side of the biceps brachii at the lower part of the arm, the brachialis is discernible. Laterally, it forms a narrow eminence extending some distance up the arm. Medially, it exhibits only a little fullness above the elbow. On the back of the arm, the long head of the triceps brachii may be seen as a longitudinal eminence, emerging from under cover of deltoideus and gradually passing into the flattened plane of the tendon of the muscle at the lower part of the back of the arm. When the muscle is in action, the medial and lateral heads become prominent. On the front of the elbow are two muscular elevations, one on either side, separate above but converging below, so as to form the medial and lateral boundaries of the antecubital fossa. The medial elevation consists of the pronator teres and the flexors, and forms a fusiform mass, pointed above at the medial epicondyle and gradually tapering off below. The pronator teres is the most lateral of the group, while the flexor carpi radialis, lying to its medial side, is the most prominent and may be traced downward to its tendon, which is situated nearer to the radial than to the ulnar border of the front of the wrist and medial to the radial artery. The palmaris longus presents no surface marking above, but below, its tendon stands out when the muscle is in action as a sharp, tense cord in front of the middle of the wrist. The flexor digitorum sublimis does not directly influence surface form. The position of its four tendons on the front of the lower part of the forearm is indicated by an elongated depression between the tendons of palmaris longus and flexor carpi ulnaris. The flexor carpi ulnaris determines the contour of the medial border of the forearm and is separated from the extensor group of muscles by the ulnar furrow produced by the subcutaneous dorsal border of the ulna. Its tendon is evident along the ulnar border of the lower part of the forearm and is most marked when the hand is flexed and adducted. The elevation forming the lateral side of the antecubital fossa consists of the brachioradialis, the extensors, and the supinator. It occupies the lateral and a considerable part of the dorsal surface of the forearm in the region of the elbow, and forms a fusiform mass which is altogether on a higher level than that produced by the medial elevation. Its apex is between the triceps brachii and brachialis, some distance below the elbow joint. It acquires its greatest breadth opposite the lateral epicondyle, and below this shades off into a flattened surface. About the middle of the forearm, it divides into two diverging longitudinal eminences. The lateral eminence consists of brachioradialis and the extensoris carpi radialis longus and brevis, and descends from the lateral supracondylar ridge in the direction of the styloid process of the radius. The medial eminence comprises the extensor digitorum communis, extensor digiti quinti proprius, and the extensor carpi ulnaris. It begins at the lateral epicondyle of the humerus as a tapering mass which is separated above from the acroneus from a well-marked furrow, and below from the pronator teres and the flexor group by the ulnar furrow. The medial border of the brachioradialis starts as a rounded elevation above the lateral epicondyle. Lower down, the muscle forms a prominent mass on the radial side of the upper part of the forearm. Below, it tapers to its tendon, which may be traced to the styloid process of the radius. The acroneus presents a triangular, slightly elevated area immediately lateral to the subcutaneous surface of the olecranon and differentiated from the extensor group by an oblique depression. The upper angle of the triangle is at the dimple over the lateral epicondyle. At the lower part of the back of the forearm, in the interval between the two diverging eminences, is an oblique elongated swelling, full above but flattened and partially subdivided below. It is caused by the abductor pollicis longus and the extensor pollicis brevis. It crosses the dorsal and lateral surfaces of the radius to the radial side of the wrist joint, whence it is continued on to the dorsal surface of the thumb as a ridge best marked when the thumb is extended. The tendons of most of the extensor muscles can be seen and felt on the back of the wrist. Laterally is the oblique ridge produced by the extensor pollicis longus. The extensor carpi radialis longus is scarcely palpable, but the extensor carpi radialis brevis can be identified as a vertical ridge emerging from under the ulnar border of the tendon of the extensor pollicis longus when the wrist is extended. Medial to this, the extensor tendons of the finger can be felt, the extensor digiti quinti proprius being separated from the tendons of the extensor digitorum communis by a slight furrow. The muscles of the hand are principally concerned, as regards surface form, in producing the thenar and hypothenar eminences, and cannot be individually distinguished. The thenar eminence on the radial side is larger and rounder than the hypothenar, which is a long, narrow elevation along the ulnar side of the palm. When the palmaris brevis is in action, it produces a wrinkling of the skin over the hypothenar eminence and a dimple on the ulnar border. On the back of the hand, the interossi dorsalis give rise to the elongated swellings between the metacarpal bones. The first forms a prominent fusiform bulging when the thumb is adducted. The others are not so marked. Arteries. Above the middle of the clavicle, the pulsation of the subclavian artery can be detected by pressing downward, backward, and medialward against the first rib. The pulsation of the axillary artery as it crosses the second rib can be felt below the middle of the clavicle, just medial to the coracoid process. Along the lateral wall of the axilla, the course of the artery can be easily followed close to the medial border of the coracobrachialis. The brachial artery can be recognized in practicality the whole of this extent along the medial margin of the biceps and the upper 2/3 of the arm. It lies medial to the humerus, but in the lower third it is more directly on the front of the bone. Over the lower end of the radius, between the styloid process and flexor carpi radialis, a portion of the radial artery is superficial and is used clinically for observations on the pulse. Veins. The superficial veins of the upper extremity are easily rendered visible by compressing the proximal trunks. Their arrangement is described on pages 660 to 662. Nerves. The uppermost trunks of the brachial plexus are palpable for a short distance above the clavicle as they emerge from under the lateral border of the sternocleidomastoideus. The larger nerves derived from the plexus can be rolled under the finger against the lateral axillary wall but cannot be identified. The ulnar nerve can be detected in the groove behind the medial epicondyle.
Section 57 of Gray's Anatomy, Part 5. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Jean Hildy Fulgham. Anatomy of the Human Body, Part 5, by Henry Gray. 12. Surface markings of the upper extremity. Bony landmarks. The bony landmarks as described above are so readily available for surface recognition that no special measurements are required to indicate them. It may be noted, however, that the medial angle of the scapula is applied to the second rib, while the inferior angle lies against the seventh. The intertubercular groove of the humerus is vertically below the acromioclavicular joint, when the arm hangs by the side with the palm of the hand forward. Articulations. The acromioclavicular joint is situated in a plane passing sagittally through the middle line of the front of the arm. The line of the elbow joint is not straight. The radiohumeral portion is practically at right angles to the long axis of the humerus and is situated about 2 centimeters distal to the lateral epicondyle. The ulnohumeral portion is oblique, and its medial end is about 2.5 centimeters distal to the medial epicondyle. The position of the wrist joint can be indicated by drawing a curved line, with its convexity upward, between the styloid processes of the radius and ulna. The summit of the convexity is about 1 centimeter above the center of a straight line joining the two processes. Muscles. The only muscles of the upper extremity which occasionally require definition by surface lines are the trapezius, the latissimus dorsi, and the pectoralis major and minor. The antero-superior border of trapezius is indicated by a line from the superior nuchal line about 3 centimeters lateral to the external occipital protuberance to the junction of the intermediate and lateral thirds of the clavicle. The line of the lower border extends from the spinous process of the 12th thoracic vertebra to the vertebral border of the scapula at the root of the spine. The upper border of latissimus dorsi is almost horizontal, running from the spinous process of the 7th thoracic vertebra to the inferior angle of the scapula, and thence somewhat obliquely to the intertubercular sulcus of the humerus. The lower border corresponds roughly to a line drawn from the iliac crest, about 2 centimeters from the lateral margin of the sacrospinalis, to the intertubercular sulcus. The upper margin of pectoralis major extends from the middle of the clavicle to the surgical neck of the humerus. Its lower border is practically in the line of the 5th rib and reaches from the 5th costochondral junction to the middle of the anterior border of deltoideus. The two lines indicating the borders of pectoralis minor begin at the coracoid process of the scapula and extend to the 3rd and 5th ribs respectively, just lateral to the corresponding costal cartilages. On the front of the elbow joint, a triangular space, the antecubital fossa, is mapped out for convenience of reference. The base of the triangle is a line joining the medial and lateral epicondyles, while the sides are formed respectively by the salient margins of the brachioradialis and pronator teres. Mucous sheaths. On the volar surfaces of the wrist and hand, the mucous sheaths of the flexor tendons can be indicated as follows. The sheath for flexor pollicis longus extends from about 3 centimeters above the upper edge of the transverse carpal ligament to the terminal phalanx of the thumb. The common sheath for the flexoris digitorum reaches about 3.5 to 4 centimeters above the upper edge of the transverse carpal ligament and extends on the palm of the hand to about the level of the centers of the metacarpal bones. The sheath for the tendons to the little finger is continued from the common sheath to the base of the terminal phalanx of this finger. The sheaths for the tendons of the other fingers are separated from the common sheath by an interval. They begin opposite the necks of the metacarpal bones and extend to the terminal phalanges. Arteries. The course of the axillary artery can be marked out by abducting the arm to a right angle and drawing a line from the middle of the clavicle to the point where the tendon of the pectoralis major crosses the prominence of the coracobrachialis. Of the branches of the axillary artery, the origin of the thoracoacromial corresponds to the point where the artery crosses the upper border of pectoralis minor. The lateral thoracic takes practically the line of the lower border of pectoralis minor. The subscapular is sufficiently indicated by the axillary border of the scapula. The scapular circumflex is given off the subscapular opposite the midpoint of a line joining the tip of the acromion to the lower edge of the deltoid tuberosity, while the humeral circumflex arteries arise from the axillary about 2 centimeters above this. The position of the brachial artery is marked by a line drawn from the junction of the anterior and middle thirds of the distance between the anterior and posterior axillary folds to a point midway between the epicondyles of the humerus and continued distally for 2.5 centimeters, at which point the artery bifurcates. With regard to the branches of the brachial artery, the profunda crosses the back of the humerus at the level of the insertion of deltoideus. The nutrient is given off opposite the middle of the body of the humerus. A line from this point to the back of the medial condyle represents the superior ulnar collateral. The inferior ulnar collateral is given off about 5 centimeters above the fold of the elbow joint and runs directly medialward. The position of the radial artery in the forearm is represented by a line from the lateral margin of the biceps tendon in the center of the antecubital fossa to the medial side of the front of the styloid process of the radius when the limb is in the position of supination. The situation of the distal portion of the artery is indicated by continuing this line around the radial side of the wrist to the proximal end of the first intermetacarpal space. On account of the curved direction of the ulnar artery, 2 lines are required to indicate its course. One is drawn from the front of the medial epicondyle to the radial side of the pisiform bone. The lower 2/3 of this line represents 2/3 of the artery. The upper third is represented by a second line from the center of the hollow in the front of the elbow joint to the junction of the upper and middle thirds of the first line. The superficial volar arch can be indicated by a line starting from the radial side of the pisiform bone and curving distalward and lateralward as far as the base of the thumb, with its convexity toward the fingers. The summit of the arch is usually on a level with the ulnar border of the outstretched thumb. The deep volar arch is practically transverse and is situated about 1 centimeter nearer to the carpus. Nerves. In the arm, the line of the median nerve is practically the same as that for the brachial artery. At the bend of the elbow, the nerve is medial to the artery. The course of the nerve in the forearm is marked by a line starting from a point just medial to the center of one joining the epicondyle and extending to the lateral margin of the tendon of palmaris longus at the wrist. The ulnar nerve follows the line of the brachial artery in the upper half of the arm, but at the middle of the arm it diverges and descends to the back of the medial epicondyle. In the forearm it is represented by a line from the front of the medial epicondyle to the radial side of the pisiform bone. The course of the radial nerve can be indicated by a line from just below the posterior axillary fold to the lateral side of the humerus at the junction of its middle and lower thirds. Thence it passes vertically downward on the front of the arm to the level of the lateral epicondyle. The course of the superficial radial nerve is represented by a continuation of this line downward to the junction of the middle and lower thirds of the radial artery. It then crosses the radius and runs distalward to the dorsum of the base of the first metacarpal bone. The axillary nerve crosses the humerus about 2 centimeters above the center of a line joining the tip of the acromion to the lower
Section 58 of Gray's Anatomy, Part 5. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recorded by Laurie Ann Walden. Anatomy of the Human Body, Part 5, by Henry Gray. Surface Anatomy of the Lower Extremity. Skin. The skin of the thigh, especially in the hollow of the groin and on the medial side, is thin, smooth, and elastic, and contains few hairs except in the neighborhood of the pubis. Laterally it is thicker and the hairs are more numerous. The junction of the skin of the thigh with that on the front of the abdomen is marked by a well-defined furrow which indicates the site of the inguinal ligament. The furrow presents a general convexity downward, but its medial half, which is the better marked, is nearly straight. The skin over the buttock is fairly thick, and is characterized by its low sensibility and slight vascularity. As a rule it is destitute of conspicuous hairs, except toward the post-anal furrow, where in some males they are abundantly developed. An almost transverse fold, the gluteal fold, crosses the lower part of the buttock. It practically bisects the lower margin of the gluteus maximus, and is most evident during extension of the hip joint. The skin over the front of the knee is covered by thickened epidermis. It is loose and thrown into transverse wrinkles when the leg is extended. The skin of the leg is thin, especially on the medial side, and is covered with numerous large hairs. On the dorsum of the foot, the skin is thin, loosely connected to subjacent parts, and contains few hairs. On the plantar surface, and especially over the heel, the epidermis is of great thickness. And here, as in the palm of the hand, there are neither hairs nor sebaceous glands. Bones. The hip bones are largely covered with muscles, so that only at a few points do they approach the surface. In front the anterior superior iliac spine is easily recognized, and in thin subjects stands out as a prominence at the lateral end of the fold of the groin. In fat subjects its position is indicated by an oblique depression, at the bottom of which the bony process can be felt. Proceeding upward and backward from this process, the sinuously curved iliac crest can be traced to the posterior superior iliac spine, the site of which is indicated by a slight depression. On the outer lip of the crest, about 5 centimeters behind the anterior superior spine, is the prominent iliac tubercle. In thin subjects the pubic tubercle is very apparent, but in the obese it is obscured by the pubic fat. It can, however, be detected by following up the tendon of origin of adductor longus. Another part of the bony pelvis which is accessible to touch is the ischial tuberosity situated beneath the gluteus maximus, and when the hip is flexed, easily felt, as it is then uncovered by muscle. The femur is enveloped by muscles, so that in fairly muscular subjects the only accessible parts are the lateral surface of the greater trochanter and the lower expanded end of the bone. The site of the greater trochanter is generally indicated by a depression, owing to the thickness of the gluteae medius and minimus, which project above it. When, however, the thigh is flexed, and especially if it be crossed over the opposite one, the trochanter produces a blunt eminence on the surface. The lateral condyle is more easily felt than the medial. Both epicondyles can be readily identified, and at the upper part of the medial condyle the sharp adductor tubercle can be recognized without difficulty. When the knee is flexed, a portion of the patellar surface is uncovered and is palpable. The anterior surface of the patella is subcutaneous. When the knee is extended, the medial border of the bone is a little more prominent than the lateral, and if the quadriceps femoris be relaxed, the bone can be moved from side to side. When the joint is flexed, the patella recedes into the hollow between the condyles of the femur and the upper end of the tibia, and becomes firmly applied to the femur. A considerable portion of the tibia is subcutaneous. At the upper end the condyles can be felt just below the knee. The medial condyle is broad and smooth, and merges into the subcutaneous surface of the body below. The lateral is narrower and more prominent, and on it, about midway between the apex of the patella and the head of the fibula, is the tubercle for the attachment of the iliotibial band. In front of the upper end of the bone, between the condyles, is an oval eminence, the tuberosity, which is continuous below with the anterior crest of the bone. This crest can be identified in the upper 2/3 of its extent as a flexuous ridge, but in the lower third it disappears, and the bone is concealed by the tendons of the muscles on the front of the leg. Medial to the anterior crest is the broad surface, slightly encroached on by muscles in front and behind. The medial malleolus forms a broad prominence, situated at a higher level and somewhat farther forward than the lateral malleolus. It overhangs the medial border of the arch of the foot. Its anterior border is nearly straight. Its posterior presents a sharp edge which forms the medial margin of the groove for the tendon of tibialis posterior. The only subcutaneous parts of the fibula are the head, the lower part of the body, and the lateral malleolus. The head lies behind and lateral to the lateral condyle of the tibia, and presents as a small prominent pyramidal eminence, slightly above the level of the tibial tuberosity. Its position can be readily located by following downward the tendon of biceps femoris. The lateral malleolus is a narrow elongated prominence, from which the lower third or half of the lateral surface of the body of the bone can be traced upward. On the dorsum of the tarsus the individual bones cannot be distinguished, with the exception of the head of the talus, which forms a rounded projection in front of the ankle joint when the foot is forcibly extended. The whole dorsal surface of the foot has a smooth convex outline, the summit of which is the ridge formed by the head of the talus, the navicular, the second cuneiform, and the second metatarsal bone. From this it inclines gradually lateralward and rapidly medialward. On the medial side of the foot, the medial process of the tuberosity of the calcaneus and the ridge separating the posterior from the medial surface of the bone are distinguishable. In front of this, and below the medial malleolus, is the sustentaculum tali. The tuberosity of the navicular is palpable about 2.5 to 3 centimeters in front of the medial malleolus. Farther forward, the ridge formed by the base of the first metatarsal bone can be obscurely felt, and from this the body of the bone can be traced to the expanded head. Beneath the base of the first phalanx is the medial sesamoid bone. On the lateral side of the foot, the most posterior bony point is the lateral process of the tuberosity of the calcaneus, with the ridge separating the posterior from the lateral surface of the bone. In front of this, the greater part of the lateral surface of the calcaneus is subcutaneous. On it, below and in front of the lateral malleolus, the trochlear process, when present, can be felt. Farther forward, the base of the fifth metatarsal bone is prominent, and from it the body and expanded head can be traced. As in the case of the metacarpals, the dorsal surfaces of the metatarsal bones are easily defined, although their heads do not form prominences. The plantar surfaces are obscured by muscles. The phalanges, in their whole extent, are readily palpable. Articulations. The hip joint is deeply seated and cannot be palpated. The interval between the tibia and femur can always be easily felt. If the knee joint be extended, this interval is on a higher level than the apex of the patella, but if the joint be slightly flexed, it is directly behind the apex. When the knee is semi-flexed, the medial borders of the patella and of the medial condyle of the femur, and the upper border of the medial condyle of the tibia, bound a triangular depressed area which indicates the position of the joint. The ankle joint can be felt on either side of the extensor tendons, and during extension of the joint, the superior articular surface of the talus presents below the anterior border of the lower end of the tibia. Muscles. Of the muscles of the thigh, those of the anterior femoral region contribute largely to surface form. The tensor fascia lata produces a broad elevation immediately below the anterior part of the iliac crest and behind the anterior superior iliac spine. From its lower border a groove caused by the iliotibial band extends downward to the lateral side of the knee joint. The upper portion of sartorius constitutes the lateral boundary of the femoral triangle, and when the muscle is in action, forms a prominent oblique ridge which is continued below into a flattened plane, and then gradually merges into a general fullness on the medial side of the knee joint. When the sartorius is not in action, a depression exists between the quadriceps femoris and the adductors, and extends obliquely downward and medialward, from the apex of the femoral triangle to the side of the knee. In the angle formed by the divergence of sartorius and tensor fascia lata, just below the anterior superior iliac spine, the rectus femoris appears, and in a muscular subject its borders can be clearly defined when the muscle is in action. The vastus lateralis forms a long flattened plane traversed by the groove of the iliotibial band. The vastus medialis gives rise to a considerable prominence on the medial side of the lower half of the thigh. This prominence increases toward the knee, and ends somewhat abruptly with a full curved outline. The vastus intermedius is completely hidden. The adductores cannot be differentiated from one another, with the exception of the upper tendon of adductor longus and the lower tendon of adductor magnus. When the adductor longus is in action, its upper tendon stands out as a prominent ridge running obliquely downward and lateralward from the neighborhood of the pubic tubercle and forming the medial border of the femoral triangle. The lower tendon of adductor magnus can be distinctly felt as a short ridge extending downward between the sartorius and vastus medialis to the adductor tubercle. The adductores fill in the triangular space at the upper part of the thigh, between the femur and the pelvis, and to them is due the contour of the medial border of the thigh, the gracilis contributing largely to the smoothness of the outline. The gluteus maximus forms the full rounded outline of the buttock. It is more prominent behind, compressed in front, and ends at its tendinous insertion in a depression immediately behind the greater trochanter. Its lower border crosses the gluteal fold obliquely downward and lateralward. The upper is part of gluteus medius and is visible, but its lower part with gluteus minimus and the external rotators are completely hidden. From beneath the lower margin of gluteus maximus the hamstrings appear. At first they are narrow and not well defined, but as they descend they become more prominent and eventually divide into two well-marked ridges formed by their tendons. These constitute the upper boundaries of the popliteal fossa. The tendon of biceps femoris is a thick cord running to the head of the fibula. The tendons of the semimembranosus and semitendinosus, as they run medialward to the tibia, are separated by a slight furrow. The semitendinosus is the more medial, and can be felt in certain positions of the limb as a sharp cord, while the semimembranosus is thick and rounded. The gracilis is situated a little in front of them. The tibialis anterior presents a fusiform enlargement at the lateral side of the tibia, and projects beyond the anterior crest of the bone. Its tendon can be traced on the front of the tibia and ankle joint, and thence along the medial side of the foot to the base of the first metatarsal bone. The fleshy fibers of peroneus longus are strongly marked at the upper part of the lateral side of the leg. It is separated by furrows from extensor digitorum longus in front, and soleus behind. Below, the fleshy fibers end abruptly in a tendon which overlaps the more flattened elevation of peroneus brevis. Below the lateral malleolus, the tendon of peroneus brevis is the more marked. On the dorsum of the foot, the tendons emerging from beneath the transverse and cruciate crural ligaments spread out and can be distinguished as follows. The most medial and largest is tibialis anterior. The next is extensor hallucis proprius, then extensor digitorum longus dividing into 4 tendons to the 2nd, 3rd, 4th, and 5th toes, and lastly peroneus tertius. The extensor digitorum brevis produces a rounded outline on the dorsum of the foot and a fullness in front of the lateral malleolus. The interossei dorsalis bulge between the metatarsal bones. At the back of the knee is the popliteal fossa, bounded above by the tendons of the hamstrings and below by the gastrocnemius. Below this fossa is the prominent fleshy mass of the calf of the leg produced by gastrocnemius and soleus. When these muscles are in action, the borders of gastrocnemius form 2 well-defined curved lines, which converge to the tendocalcaneus. The medial border is the more prominent. At the same time the edges of soleus can be seen forming, on either side of gastrocnemius, curved eminences, of which the lateral is the longer. The fleshy mass of the calf ends somewhat abruptly in the tendocalcaneus, which tapers in the upper 3/4 of its extent, but widens out slightly below. Behind the medial border of the lower part of the tibia, a well-defined ridge is produced by the tendon of tibialis posterior during contraction of the muscle. On the sole of the foot, the abductor digiti quinti forms a narrow rounded elevation on the lateral side, and the abductor hallucis a lesser elevation on the medial side. The flexor digitorum brevis, bound down by the plantar aponeurosis, is not very apparent. It produces a flattened form, and the thickened skin underlying it is thrown into numerous wrinkles. Arteries. The femoral artery, as it crosses the brim of the pelvis, is readily felt. In its course down the thigh, its pulsation becomes gradually more difficult of recognition. When the knee is flexed, the pulsation of the popliteal artery can easily be detected in the popliteal fossa. On the lower part of the front of the tibia, the anterior tibial artery becomes superficial and can be traced over the ankle into the dorsalis pedis. The latter can be followed to the proximal end of the first intermetatarsal space. The pulsation of the posterior tibial artery becomes evident near the lower end of the back of the tibia, and is easily detected behind the medial malleolus. Veins. By compressing the proximal trunks, the venous arch on the dorsum of the foot, together with the great and small saphenous veins leading from it, are rendered visible. Nerves. The only nerve of the lower extremity which can be located Section 59 of Gray's Anatomy, Part 5. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Read by Laurianne Walden. Anatomy of the Human Body, Part 5, by Henry Gray. Surface markings of the lower extremity. Bony landmarks. The anterior superior iliac spine is at the level of the sacral promontory, the posterior at the level of the spinous process of the second sacral vertebra. A horizontal line through the highest points of the iliac crests passes also through the spinous process of the fourth lumbar vertebra, while, as already pointed out, the transtubercular plane through the tubercles on the iliac crests cuts the body of the fifth lumbar vertebra. The upper margin of the greater sciatic notch is opposite the spinous process of the third sacral vertebra, and slightly below this level is the posterior inferior iliac spine. The surface markings of the posterior inferior iliac spine and the ischial spine are both situated in a line which joins the posterior superior iliac spine to the outer part of the ischial tuberosity. The posterior inferior spine is 5 cm, and the ischial spine 10 cm below the posterior superior spine. The ischial spine is opposite the first piece of the coccyx. With the body in the erect posture, the line joining the pubic tubercle to the top of the greater trochanter is practically horizontal. The middle of this line overlies the acetabulum and the head of the femur. A line used for clinical purposes is that of Nelaton, which is drawn from the anterior superior iliac spine to the most prominent part of the ischial tuberosity. It crosses the center of the acetabulum and the upper border of the greater trochanter. Another surface marking of clinical importance is Bryant's triangle, which is mapped out thus. A line from the anterior superior iliac spine to the top of the greater trochanter forms the base of the triangle. Its sides are formed respectively by a horizontal line from the anterior superior iliac spine and a vertical line from the top of the greater trochanter. Articulations. The posterior superior iliac spine overlies the center of the sacroiliac articulations. The hip joint may be indicated, as described above, by the center of a horizontal line from the pubic tubercle to the top of the greater trochanter, or, more generally, it is below and slightly lateral to the middle of the inguinal ligament. The knee joint is superficial and requires no surface marking. The level of the ankle joint is that of a transverse line about 1 cm above the level of the tip of the medial malleolus. If the foot be forcibly extended, the head of the talus appears as a rounded prominence on the medial side of the dorsum. Just in front of this prominence, and behind the tuberosity of the navicular, is the talo-navicular joint. The calcaneo-cuboid joint is situated midway between the lateral malleolus and the prominent base of the fifth metatarsal bone. The line indicating it is parallel to that of the talo-navicular joint. The line of the fifth tarso-metatarsal joint is very oblique. It starts from the projection of the base of the fifth metatarsal bone, and if continued would pass through the head of the first metatarsal. The lines of the fourth and third tarso-metatarsal joints are less oblique. The first tarso-metatarsal joint corresponds to a groove which can be felt by making firm pressure on the medial border of the foot 2.5 cm in front of the tuberosity of the navicular bone. The position of the second tarso-metatarsal joint is 1.25 cm behind this. The metatarsophalangeal joints are about 2.5 cm behind the webs of the corresponding toes. Muscles. None of the muscles require any special surface lines to indicate them, but there are 3 intermuscular spaces which occasionally require definition. These are the femoral triangle, the adductor canal, and the popliteal fossa. The femoral triangle is bounded above by the inguinal ligament, laterally by the medial border of sartorius, and medially by the medial border of adductor longus. In the triangle is the fossa ovalis, through which the great saphenous vein dips to join the femoral. The center of this fossa is about 4 cm below and lateral to the pubic tubercle. Its vertical diameter measures about 4 cm, and its transverse about 1.5 cm. The femoral ring is about 1.25 cm lateral to the pubic tubercle. The adductor canal occupies the medial part of the middle third of the thigh. It begins at the apex of the femoral triangle and lies deep to the vertical part of the sartorius. The popliteal fossa is bounded, above and medially, by the tendons of semimembranosus and semitendinosus, above and laterally by the tendon of biceps femoris, below and medially by the medial head of gastrocnemius, below and laterally by the lateral head of gastrocnemius and the plantaris. Mucous sheaths. The positions of the mucous sheaths around the tendons about the ankle joints are sufficiently indicated in Figures 1241 and 1242. Arteries. The points of emergence of the three main arteries on the buttock, that is, the superior and inferior gluteals and the internal pudendal, may be indicated in the following manner. With the femur slightly flexed and rotated inward, a line is drawn from the posterior superior iliac spine to the posterior superior angle of the greater trochanter. The point of emergence of the superior gluteal artery from the upper part of the greater sciatic foramen corresponds to the junction of the upper and middle thirds of this line. A second line is drawn from the posterior superior iliac spine to the outer part of the ischial tuberosity. The junction of its lower with its middle third marks the point of emergence of the inferior gluteal and internal pudendal arteries from the lower part of the greater sciatic foramen. The course of the femoral artery is represented by the upper two-thirds of a line from a point midway between the anterior superior iliac spine and the symphysis pubis to the adductor tubercle, with the thigh abducted and rotated outward. The profunda femoris arises from it about 1 to 5 centimeters below the inguinal ligament. The course of the upper part of the popliteal artery is indicated by a line from the lateral margin of semimembranosus at the junction of the middle and lower thirds of the thigh, obliquely downward to the middle of the popliteal fossa. From this point it runs vertically downward for about 2.5 centimeters, or to the level of a line through the lower part of the tibial tuberosity. The line indicating the anterior tibial artery is drawn from the medial side of the head of the fibula to a point midway between the malleoli. The artery begins about 3 centimeters below the head of the fibula. The dorsalis pedis artery is represented on the dorsum of the foot by a line from the center of the interval between the malleoli to the proximal end of the first intermetatarsal space. The course of the posterior tibial artery can be shown by a line from the end of the popliteal artery, that is, 2.5 centimeters below the center of the popliteal fossa, to midway between the tip of the medial malleolus and the center of the convexity of the heel. Its main branch, the perineal artery, begins about 7 or 8 centimeters below the level of the knee joint, and follows the line of the fibula to the back of the lateral malleolus. The medial and lateral plantar arteries begin from the end of the posterior tibial. The medial extends to the middle of the plantar surface of the ball of the great toe. The lateral to within a finger's breadth of the tuberosity of the fifth metatarsal bone. From this latter point the plantar arch crosses the foot transversely to the proximal end of the first intermetatarsal space. Veins. The line of the great saphenous vein is from the front of the medial malleolus to the center of the fossa ovalis. The small saphenous vein runs from the back of the lateral malleolus to the center of the popliteal fossa. Nerves. The course of the sciatic nerve can be indicated by a line from a point midway between the outer border of the ischial tuberosity and the posterior superior angle of the greater trochanter to the upper angle of the popliteal fossa. The continuation of this line vertically through the center of the popliteal fossa represents the position of the tibial nerve, while the common peroneal nerve follows the line of the tendon of biceps femoris. The lines for the deep perineal nerve and the continuation of the tibial nerve correspond respectively to those for the anterior and posterior tibial